or on the floor for an extended period of time, and we'll actually be going back to the Senate floor later this afternoon. So we will wait for a couple more members of my committee. So hold tight for another minute or so. Good afternoon and welcome to the Education, Health, and Environmental Affairs Committee for today, March 2nd. Again, for those who came on late, we went late on the floor of the Senate and we had to postpone our beginning time. We have about 12 or 13 bills. We'll try to do it expeditiously. We're probably going the order of the bill numbers. We may hop around a little bit. Each bill will be led off by the sponsor of the bill, who will present the bill, then followed by witnesses. The leading proponent may have up to 5 minutes, Subsequent witnesses may have up to 2.5 minutes. I will let you know if there's no opposition to the bill, both oral and written. So you may want to adjust your comments and be even more concise than you expect to be. With that, we're going to start with Senator Lamb. Senate Bill 684, Licensure of Certified Midwives Act. Senator Lamb will be followed by Lauren Arrington, Jan Krebs, and Andrea Williams Muhammad. Then we'll take questions. And then I can safely announce there is no opposition, neither written nor oral. So please take that in consideration. Then we have Senator Feldman if he's here. If not, we'll go to Senator Augustine. Okay, with that, Senator Lamb, you have the floor.
Great, thank you, Mr. Chairman, members of the committee. This is Senate Bill 684. For the record, Clarence, I'm Senator District 12. So I'm going to try to summarize what looks like a long bill, but it's actually pretty straightforward. The bill's purpose is quite simple. It creates a midwifery licensure category called, quote, certified midwife under the Board of Nursing in order to expand the number of qualified midwives. This bill is also part of a broader strategy to address health disparities in maternal and infant health outcomes here in Maryland. We already currently recognize licensure for certified nurse midwives, as well as certified professional midwives. These folks are also called, this last category is also called licensed direct entry midwives in Maryland. So there's two categories of midwives that we already licensed. This would add a third pathway to help increase access, increase the pool of midwives available. Certified midwives and certified nurse midwives have identical graduate midwifery training. They go through the same training, they take the same certification exam. Because there's no licensure process for certified midwives in Maryland, They generally live and work in other states that do provide licensure for them, like Delaware, for example, that's neighboring us. We need every trained and capable healthcare worker to be working at their full capacity, given particularly the shortage of such healthcare workers in our state. Licensure for certified midwives will help grow the women's health workforce, increase access to high quality maternal, gynecological, and primary care here in Maryland. And this bill also helps improve accessibility and options for those who want to give birth at home or in a birthing center. In the written testimony, I've included just a few key examples from the rather concerning recent trends in the data pertaining to maternal mortality, both in the US and in Maryland. The maternal mortality ratio, or the MMR, is a number of maternal deaths per 100,000 live births in a specific period of time. The MMR in the US was its lowest point in 1987, with 6 maternal deaths per 100,000 live births. But by 2017, just a few years ago, our MMR in the state in the nation had risen fivefold to 31 maternal deaths per 100,000 live births. In Maryland, I think as most of you are, there's a particularly large disparity between maternal mortality rates amongst women of color, particularly Black women, contrasting that with white women. According to the 2019, this is the state's own maternal mortality review report, during the period from 2013 to 17, the maternal mortality rate for Black women was 4 times higher than the rate for white women. And looking at the data comparing the 5-year period, even before that, from 2008 to 2012, to the more recent 5-year period from 2013 to 2017, the maternal mortality rate for white women actually decreased by 35%, by more than a third, while the maternal mortality rate for Black women increased by 12% during that same time period. So huge disparities here that we're seeing across the state. And there are similar disturbing trends in the maternal mortality and mortality data. If we look at disparities between people living in urban versus rural areas between the periods from 07 to 15, rural residents had a 9% greater probability of severe maternal mortality and compared to urban residents. There are a variety of reasons for this. Workforce shortages are among some of the leading contributing factors. During the 10-year period from 2004 to 14, 9% of rural counties lost access to obstetric services, while another 45% of rural counties have no hospital obstetric services at all. So studies show that midwifery care is associated with lower rates of intervention, greater cost effectiveness, increased patient satisfaction, improved care. Midwifery also supports improved clinical outcomes in diverse communities and rural areas as well. Currently, certified midwives are excluded from the state's midwifery licensure process. So this third category is called certified midwives are excluded from the current licensure process. But they are generally able to get licensed in other states to practice as healthcare workers. The fiscal note for this bill, you'll see that it explains the various categories and definitions of different types of midwives. There are 2 existing already. This one would add that third one called certified midwives. And so, you'll find that the only difference that's listed here between certified midwives and certified nurse midwives, so the key difference there is nurse, is that prior to entering the midwifery graduate program, their schooling or their training, the certified nurse midwives have to have completed a degree in nursing, which would make sense given the title. And whereas the certified midwives can get a degree in another field, in another health or science field. So as a result, certified midwife students take some additional coursework as prerequisites before they begin their midwifery graduate education. Then they complete the same exact program that the certified nurse midwives complete. They also take the same national certification exam. They're certified by the same entity, the national accrediting body, and they have the same scope of practice and they work in the same settings. But currently, the certified nurse midwives are licensed by the state, whereas certified midwives, which we're trying to add by this bill, are not. So these highly educated and certified healthcare workers generally choose to live in other states rather than Maryland. This bill would help, create a pathway for them to get certified here in the state and hopefully keep them here as well. As it stands now, some people interested in midwifery can't get into the profession because they don't have the time or resources to go back to nursing school to get a nursing degree. to become a certified nurse midwife, which is the current existing pathway. If they have an undergraduate degree, typically in health or science, they can enter midwifery as a certified midwife, this new category we're creating, but only in states that offer licensure for this type of midwife. So since we don't have a licensure program here in Maryland, we're contributing to the conditions that reduce the availability of these types of skilled healthcare workers and midwives in our state. Midwifery practice is also important because it reflects the needs of individual women in their communities. It emphasizes women-centered care. It supports ongoing efforts. This legislation, we believe, will support ongoing efforts to ensure midwifery services are available and accessible to all Maryland communities, and can help attract and retain certified midwives in our state by expanding access to highly qualified midwives to access to our residents. And in closing, you'll see that there's a broad base of support across many different fields, including the Nurse Midwives Association, the American College of OBGYN, the Hospital Association, even the Board of Nursing with amendments, the Nurses Association, March of Dimes, and a variety of legislative caucuses that you'll see there. So there are some technical amendments that were requested by the Board of Nursing, which we accepted as sponsor amendments, and this would help simply improve the alignment of the bill with existing language in Title VIII of the Health Occupations article. And with that, let me close and ask the committee for a favorable report and turn it over to other members of the panel.
Thank you, Senator. Let's go to Lauren Arrington. And again, there is no opposition to the bill. Ms. Arrington.
Thank you. Good afternoon, Chair Pinsky and Senator Lamb and other members of the committee. My name is Lauren Arrington, and I've practiced as a nurse midwife for over 10 years at a Baltimore area hospital. I also teach midwifery at Frontier Nursing University, and I'm here today representing the Maryland affiliate of the American College of Nurse Midwives. We are privileged to urge the committee to support Senate Bill 684, Maryland Licensure of Certified Midwives Act. As midwives, we are dedicated to being with women. That is our cause. We are dedicated to it because we find that having a competent and caring midwife allows women autonomy in their healthcare choices and better health outcomes for both mothers and babies. By supporting this bill, you will give women in Maryland more options to choose the perinatal healthcare provider that they want, and you'll encourage skilled certified midwife providers to live and serve in Maryland. There's evidence that in states where access to midwifery care is high, perinatal outcomes are better, with lower rates of cesarean birth, preterm birth, and low birth weight infants. In addition, patients have more choices, and this is particularly important for expanding opportunities for racial congruence with healthcare providers. There's evidence that when Black women receive care from a provider of their same racial background, they and their newborns have better outcomes. The Maryland Licensure of Certified Midwives Act will open up another pathway to become a midwifery provider. For individuals like myself who have a bachelor's degree in a non-nursing field, this is a direct path to becoming a perinatal healthcare provider. This pathway allows more women of color to become midwives and to serve the women of color seeking their services. I urge favorable report of Senate Bill 684. Thank you for your time and commitment to expanding healthcare options and improving perinatal outcomes for Marylanders.
Thank you, Ms. Arrington. Let's go to Jan Krebs, please.
Thank you, Chair Pinsky and members of the committee for being willing to listen to us today. My name is Jan Krebs. I am the legislative chair for the ACNM Maryland affiliate. We have some evidence that licensing CMs improves the diversity of our profession. I recently polled a group of certified midwives in the Northeast and found that about a third of them are Black or people of color, which is higher than our average for our total population of certified nurse midwives and certified midwives. We also know that the percentage of certified midwife students are increasingly providing access for women of color. We do know that certified midwives also are somewhat more likely to work in birthing centers. And the more midwives we add, the more access we can add outside of the obvious work. If we look at where OBGYN providers are in Maryland, we know we have healthcare shortages. Adding midwives is part of the strategy. It's not all of it, but it's part of it. But the most common question I get is this thing about why a new title? And the answer is simple. We can't license people as nurse midwives unless they're also nurses. But a number of highly qualified college graduates would like to become midwives. So if we put them back through nursing school, we take a spot in a nursing program that someone else who wants to practice as a bedside nurse could have. And that takes more time for them to become a midwife. Once they're in school, there truly is no difference. Like Laura and I teach at a midwifery education program. I'm at Jefferson in Philadelphia, which is an online program. All of our students have the same academic classes, the same clinical experiences, the same competencies on graduation, and the same national certifying exam. Our profession mandates a single standard. So nursing is an advantageous way for many people who make up their mind later to come into midwifery. For those who know what they want, the certified midwife is simply a more direct route.
Thank you,
So
Ms. Krebs.
thank you. Thank you.
Thank you very much. Let's go to Ms. Williams-Mohammed.
Good afternoon, committee chairman and members of the committee. My name is Andrea Williams-Mohammed, and I am the co-chair of the Reproductive Health Equity Alliance of Maryland. That group is a cohort of local birth advocates and policy writers in support of reproductive rights and justice throughout the state of Maryland. We stand in support of this bill, and I will not carry my testimony, but to just second the testimony that has been given by my comrades before me. The one note that I will add is what this means in terms of community, and why this practice, this certain category of midwives, is important. Simply because our scope of practice, and when I say our, because I am a former midwifery student who stopped her studies because I realized that I would not be able to serve in the state of Maryland. And my ties to Maryland are very strong, and that was not an option for me. So with that being said, the scope of practice is much different for those who serve in this kind of entry into midwifery, meaning that we tend to go to our clients instead of our clients coming to us. So we get to have a more personal, intimate relationship with our clients and their families. We get to notice things that many providers may not have the opportunity or time to notice. And we provide that one-on-one contact. This is shown to prove, as Lauren Arrington stated in her testimony, to help with maternal disparities between Black women, white women. And so that really basically is the gist of why we stand in support as REAM, and why me personally and professionally stand in support of this amendment. Thank you for your time.
Thank you, Ms. Williams-Mohammed. Okay, questions for the sponsor or the advocates? I see Senator Riley has a question.
Thank you. Thank you very much, Mr. Chairman. Good bill, Senator Lamb. 35 years ago, my wife and I had our fourth child at a birthing center over on Democracy Boulevard with a midwife. It was spectacular, and also a significantly lower cost than going into a hospital or having an OBGYN assist with us. The question I have for you is, do the certified midwives need a collaborative agreement with the physician in order to practice?
If I can answer that, certified midwives and certified nurse midwives are licensed independent providers. Certified midwives under this law would have the same autonomy that CNMs have. We all know that we need a consulting physician because none of us are surgeons. That's part of our standards of practice, but there's not a mandated set of written agreements.
Okay, thank you very much.
You're welcome.
Mr.
And
Chairman.
this doesn't change that. That's current practice. This doesn't
Okay,
change
that's
that.
fine.
This just changes another way.
It's good, Bill.
Yeah.
We've used it. I'm all in.
Thank you.
Okay, seeing no opposition, Senator Carozza.
Thank you. Thank you, Senator Lamb. I'm learning a lot about midwife services today. So my specific question is on page 6 of the bill, lines 1 and 2. I just am trying to understand if your bill intends to include midwife services for abortion.
So this doesn't touch on abortion at all. It has nothing to do with that. It doesn't, abortions are actually governed under a different section of the law under Health General. This is really just dealing with their training and just creates another training path that would qualify for these people to get licensed.
Would you be open to an amendment that would clarify that, since there seems to be some questions about that?
I don't think I mean, from my perspective, I don't see much of a question here because I think it's really a different part of the statute. This is really just in health occupations. And rather than grabbing another part of the statute and dragging it in, I'd rather just keep this focused on health occupations, just solely focused on creating another training pathway for them. This doesn't touch on anything related to that. It's completely a different section of the statute. This is just health occupations of creating a new pathway for training.
Okay, so your response, I guess your response is that the bill is not intended to cover midwife services for abortion, that those who might have concerns that this would be, that your bill would create an alternative funding stream for abortion. You're saying that is not the intention of this bill. Is that?
It's not, and it doesn't really touch on that at all. You know,
Okay.
if folks want to address abortion, that would be a different bill. And that's why I'm kind of hesitant to grab other parts of the statute in here.
Okay, I just wanted to clarify that. Thank you, Senator Lamb.
Okay, that concludes the hearing on Senator Lamb's bill. We're going to move on to Senate Bill 706, Senator Feldman on pharmacist laboratory tests. Senator Feldman will be followed by Jonathan Cohen, Adamola R, Rob Garagiola, and then we'll, after taking questions, we'll move on to those signed up unfavorably. Senator Feldman, welcome.
Thank you, Mr. Chair, members of the committee. Let me just start by saying there is a fair amount of opposition you'll see in your folder to the bill, and I would sort of characterize you've got, and this committee knows more than any other committee when we talk about scope of practice, you've got some opposition testimony, quite frankly, that deal with economic self-interest that this bill would impact. And then you have some other opposition testimony, which are legitimate concerns have been raised, which I think can be dealt with in a different way with some amendments. So I need to kind of just put that out there because sometimes I think this committee with scope of practice, no matter how good a bill is, how good the policy is, and how good it is for constituents, you're going to draw opposition because you're hitting somebody in their pocketbooks. And some of the opposition here is in that realm. So let me also say, you know, that we've talked a lot this session about it's a different world. We've learned a lot in the last year. We're operating and living differently, and we have to pass some laws to reflect that. I mean, my committee's dealing with, and I know Senator Kagan's dealing with telehealth. It is a different world. And so this bill, I think, speaks to that. So much of the current discussions in the country deal with COVID. Not surprisingly, we're in the middle of a pandemic. And at the same time, there are reforms that are important on other public health fronts that have been impacted by COVID. And I think we're going to be experiencing COVID aftershocks for years to come. And so what do I mean by aftershocks? So in the area of routine health wellness preventative screening, generally, if you were to Google that topic right now, what you would find is a voluminous amount of literature citing plummeting routine screenings due to COVID-19. And the reduction in those screenings, no doubt, are going to lead to missed early diagnosis and increased mortality on a whole variety of fronts. And so what 706 actually is attempting to do is kind of address these COVID aftershocks by establishing what I think is a very common sense, very narrowly focused, and I want to emphasize, 3-year pilot project, okay? This is a pilot program, what the bill calls for, with a sunset provision at the end, which would expand pharmacy screenings, the types of screenings and lab tests that licensed pharmacists can order and administer very safely. And that's kind of what we're getting at. And in terms of what type of tests right now a pharmacist can perform, it's very restricted, severely so in the state of Maryland, to a handful of very simple tests, whether it's blood glucose, cholesterol tests. We know they can, pharmacists can administer immunizations. They've done 3 million vaccines over the past 5 years in our state and some others. But last year we expanded that to COVID-19 testing. We did actually step in. And interestingly, the HHS at the federal level, in doing so, in announcing that expansion, let me just recite Assistant Secretary of HHS last year, Dr. Brett Greer, and he said as follows: "We are authorizing licensed pharmacists to order and administer COVID-19 tests to their patients. The accessibility and distribution of retail and independent community-based pharmacies make pharmacists the first point of contact with a healthcare professional for many Americans." That was just this past year when we expanded the authority of pharmacists to get into COVID testing. So since that authorization, our community pharmacists have really been at the center in many communities for COVID testing and vaccine administration. And demand for testing at these local pharmacies has been pretty clear during the pandemic. Convenience, it's about weekend hours. You don't need an appointment. In fact, 90% of Americans live within 5 miles of a community pharmacy. So, for example, in those communities where, quite frankly, it's underserved. You don't have a lot of primary care physicians in a particular community, or you don't even have a primary care provider at all. These communities can really benefit what I'm pitching here in Senate Bill 706. So 706 is designed to build on this model that's evolved over the past year. So what's envisioned here in 706 specifically is proposing an the expansion of pharmacy screenings and the type of lab tests that can order and administer. And what we're talking about, and again, authorizing pharmacists to do these kinds of tests that they can't currently do under Maryland law. We would talk about PSA screening, genetic screening, and antibody screening, cardiovascular, diabetes, nutritional, and even cancer. There's been a lot of innovation in lab developed tests over the past year, and most of the screenings would be directed towards, again, self-pay situations, $50 to $100 range, but we're really talking about lab tests that can be very safely administered and with a certain body specimen. So to be clear, we're talking about screenings for health awareness and early disease detection, not for diagnosis. So under the bill, if you read it, if the results of the screenings are not within certain desired ranges, the bill requires the pharmacist to provide the results to the patient's primary care provider or health practitioner for further analysis and care. And then the Board of Pharmacy would report back to the General Assembly with recommendations at the end of this 3-year pilot program to see how it's working. And so, as I said at the outset, there is opposition, a fair amount of it's economic self-interest. I mean, the docs and the nurses don't want the pharmacists getting into this space. And as I would just say that I don't think that that's not our primary job here in the legislature. Our primary job, I think, is to enact policy to protect our constituents, giving greater access to a variety of healthcare, however you define that. And I think for all those reasons, Mr. Chair, I know there'll be questions, but I'd ask for a favorable on a 706. Again, a limited duration 3-year pilot project expanding what pharmacists can do in our state.
Senator, can you stay around, or do you have
Yes.
to go back to committee?
No, I'll stick around. I would like to hear some of the testimony for sure.
Okay, so we will take the other favorables and then take questions for the sponsor or the other advocates. We'll have Mr. Cohen, followed by Ademola Ari from the Pharmacists Association. Your name might be longer and maybe it was cut off. I'm not sure. And then Mr. Graziola. Mr. Cohen.
Thank you, Mr. Chairman. My name is Jonathan Cohen. I'm president and CEO of 2020 Gene Systems. We are a clinical lab company based in Rockville, Maryland. Behind me are two of our lab technicians that we've been working round the clock on COVID testing. We service a number of Maryland nursing homes and have a contract with Montgomery County for COVID testing. I want to commend Senator Feldman for this bill. I am strongly in support of it. I want to emphasize that when you look at who can currently order lab tests in Maryland, this is frankly baby steps in the right direction. So currently, under current law and regulations, among others, in addition to doctors and nurse practitioners, podiatrists, dentists, chiropractors can order any lab tests from any part for any ailment or disease or part of the body. Employers, to a limited extent, can order lab tests. And in many cases, consumers can order lab tests, and as long as they are consulted by a telemedicine provider, which frankly is a stranger, an impersonal stranger. We think it's much more protective for Maryland patients to have a pharmacist, somebody that they may know, that knows their family, that can look them in the eye and discuss with them their concerns. So I want to emphasize a few key points, some guardrails, as Senator Feldman mentioned, that have been wisely put into this bill. As indicated, this is not for disease definitive diagnosis. This is for screening. This is for early detection. And there's a requirement in the bill as amended that in the event a value or the tested analyte is out of range, that the primary care physician would be notified. So this is not in any way trying to replace the role of a doctor by a pharmacist. And as indicated, this is a 3-year pilot. So we'll learn from it and tweaks can be made if necessary after the pilot. But I can tell you that we sell a lot of tests to pharmacists right now, in particular, COVID antibody tests that were authorized by the FDA. And this is an emerging trend. Pharmacists have now the authority to administer these rapid antibody tests. And so far, it's gone very, very well. They like it, the patients like it. There does not seem to be any problem with it. So we believe that after COVID, there will be increasing interest and increasing demand for people to be able to go around the corner and access various tests. And I think this bill does this in a very medically responsible way and will benefit Marylanders while protecting their health. Thank you for taking the time to hear my testimony this afternoon.
Thank you, Mr. Cohen. Let's go to representative from the Community Pharmacists Association.
Good afternoon, Chair Pensky and committee members, and thank you for the opportunity to provide oral testimony in favor of Senate Bill 706. My name is Ademola Ari. I'm a manager of state government affairs at the National Community Pharmacists Association. Also like to thank Senator Feldman for his support of this bill. I'm recognizing the value that pharmacists bring in and forging ahead to utilize this expertise and skills for the health of all Marylanders. So NCPA does represent independent community pharmacists across the United States, including about 395 pharmacies in Maryland. These community pharmacies are one of the most successful healthcare providers, as we've heard on multiple occasions already. So really, I just want to touch on why this bill is important. It's about linking patients to care and optimizing prevention measures, which at this point remains an access challenge. And because pharmacists are easily accessible, many patients do engage with their pharmacists frequently on a monthly basis at a minimum. And just like many other medical professions, the pharmacy profession, they're highly trained. We have evolved from just dispensing medications and product reimbursement-based industry to, additional training. And we've built these patient relationships and provider relationships that can be very useful for the outcomes that we look for, and to help participate in care coordination efforts. So this invaluable combination of clinical ability and accessibility should be engaged for prevention measures, as we've seen with COVID-19 testing and also administering of COVID vaccines. So it's just another opportunity to expound on some of the value that have been shown so far from the pharmacy community. And on the patient side as well, the ease of access and the chance to be more aware about their healthcare. So not just about dispensing that test, but also being able to converse with the patient, discuss with them, and keep them in track, so on and so forth. So it's very important to leverage pharmacist knowledge and accessibility, okay? And again, their relationships that they have with the community. And this bill does just this by allowing pharmacists to order and administer health screening tests, which are then analyzed in a high complexity lab. So it does have real life implication and brings value to Maryland's healthcare system. And so I do appreciate the opportunity to provide testimony in support of this bill. And I urge a favorable committee report on the bill, and welcome any questions you may have. Thank you.
Thank you, Mr. Array. Mr. Garagiola.
Chairman and members of the committee, Rob Garagiola with Compass on behalf of 2020 Gene Systems. I want to thank Senator Feldman for sponsoring Senate Bill 706. And certainly would urge a favorable committee report. As was mentioned, this is not, treading on completely new ground. We're seeing the role of community pharmacists, particularly during the pandemic, with testing and with vaccinations, and the access point that they provide, being in the community, has been critical over the last year throughout the pandemic. As was mentioned, this bill focuses on screenings and not diagnosis. As Senator Feldman had mentioned, we've seen a substantial reduction in screenings overall. And the NIH, the National Cancer Institute, American Cancer Society, many other well-renowned government bodies, as well as national health associations, have raised substantial concern with this reduction in simple health awareness screenings. That there's a big concern. And I would urge you to Google yourself because you'll see, page after page emphasizing this. We're going to be dealing with, I think as Senator Feldman said, the aftershocks of the pandemic for many, many years, and we don't need to. And so really what this bill is trying to do is provide a simple access point for a pilot program of 3 years to enable individuals to have an ease in getting these screenings, to identify illnesses, and to seek treatment if necessary. There's much has changed because of the pandemic. I think there's going to be long-term change. More people will be teleworking. More people will be shopping online. And we think that what we've seen in the pharmacy community with them being a greater access point for healthcare delivery, that's something that should be given consideration as well. The legislation has the support of the National Community Pharmacists, the Maryland Pharmacists, Maryland chain drugstores. Obviously, you're going to be hearing some of the scope of practice issues that I think Senator Feldman dealt with as well. I think the OAG, they raised a cabbage patchwork of issues that I think are readily addressed. Talking about seeking patient protections, we believe that it's already within statute, but making cross references to Title 17 and Title 13 can easily remedy the concerns that they raise. And with that, Mr. Chair, members of the committee, we would urge a favorable committee report.
Thank you, Mr. Graziola.
Thank you.
Cabbage patch of issues. That's an interesting phrase. Thank you.
You're welcome.
Let's go to a question from Vice Chair Kagan first, followed by Senator Carrozza.
Thank you, Mr. Chairman. Thank you, Senator Feldman, for your clear explanation of this bill. And Jonathan, it's nice to see you again. I have a quick question based on testimony, opposing testimony, and sometimes we kind of want to be able to hear you rebut what they say. So they express a concern that there isn't sufficient, they said there is no follow-up with the primary care provider if patients are screened for early detection of disease. And then they also wonder about whether the pharmacist would have the patient's past medical history and information about comorbidities. So I wonder if you could speak to those two items, please, and how your bill might address it. Thank you.
Is that for me or for?
That is your call. Is that for Jonathan?
Oh, I mean, maybe I'll let John. I would say the bill very specifically says if you're outside of range, the pharmacist is required and shall send that off to the primary physician. So I'm not sure that is an issue. As far as the second part, John, as far as not having all the records and all the rest, I mean, you know, as I say, I expect the docs wouldn't like this because it gets into their space. So you don't have to, you know, make that appointment for 2 weeks ahead. You're going to be able to go to the corner CVS pharmacist. So I'm sure MedCai, they don't like this. Again, it hits their pocketbook. But could I let John maybe more thoroughly answer the question? That might be easier.
Thank you,
Right, thank you. So yes.
Thoroughly, but concise.
Yeah, sorry.
Okay, so to the first part of the question, yes, the bill as amended does require reporting of out-of-range results to the primary care. As far as the patient history is concerned, very often that will depend on the test. So in our case, for example, for certain tests, we have a patient questionnaire, and the pharmacist can see that along with the patient. So it will vary. And of course, pharmacists often know quite a bit about their patients. In many cases, they have been seeing them for years. So it's a lot better than a stranger on the internet with telemedicine. So I think in many respects, this is a step forward in that regard.
Thank you, Jonathan. I heard you. Thank you, Mr. Chairman.
Senator Carrozza, followed by Senator Washington.
Thank you, Mr. Chair, and thank you, Senator Feldman, for bringing this bill to our attention. And my question is for you, the Senate sponsor. I'm trying to make healthcare decisions as various issues come through our committee with the lens of the COVID-19 emergency, as I think, you know, so many of our issues in this Maryland General Assembly were approaching that way. So I wanted to ask you, in my district, which is more of a rural district, a lot of my constituents do depend on their pharmacists, as they're often their first line and sometimes their only line of medical care. And I wanted to ask you if the timing of your introducing this, has COVID-19 prompted this bill at this time, and is that then directly tied to increasing services for those, particularly in more rural areas?
Yeah, I mean, I think I said that at the outset. I think the world's changed. I mean, and we see what a useful role our community pharmacies can play, whether it's COVID testing, vaccines, and all the rest. And right now they're really hamstrung to these, like, you know, I think there's like 6 tests they can do. All I'm saying with this bill, and again, it's a pilot project. If what I'm saying, you know, is not the case in 2-3 years, it sunsets. But I think it's worth a try here because I think the experience, people want a convenience, you know, evening hours, all the kinds of things that are problematic in a community like yours from an access standpoint. I think this would be an important access point for your Senate district and the folks you represent for I think all the reasons. So the answer is yes. Like a lot of stuff we're doing this session, we're responding to the reality of the world that now exists, not the one that existed, you know, pre-last March. And the demand, I guess the demand is off the charts for more, you know, for pharma. The demand is, I think, speaks for itself here. People want that kind of convenience for a variety of screenings and such. So.
Mr. Chairman, if I may just add.
We're going to go to the next question, Mr. Cohen.
Okay.
I think the sponsor did a great job. Senator Washington. Need to unmute, Mary.
People don't even have, you know, direct care providers. I mean, there's a lot of communities that are underserved.
There you go.
Doctors around.
Okay. Senator Washington.
Yeah. I'll start again. Thanks for bringing this bill. Like my 2 colleagues before me, I'm inclined to do things that expand access, rural and also for communities that are underserved, you know, in my district and across the state. I want to better understand. So this could be for the sponsor or the pharmacist. on page 3, yes, page 3, when we talk about exactly what the board is adopting regulations regarding. So just, we have a whole list of types of things that they're being authorized to do. I'm wondering if you could just put it in sort of layman terms, what kinds of tests are measuring biomarkers and ribonucleic protein antibodies. Is this another word for saying blood tests and urine tests? What is that exactly? And then I'll have a follow-up.
Mr. Chair, could I send that question to Mr. Cohen? I think he's probably in a good position to answer that.
Absolutely.
Okay.
Thank you for the question. So yes, so it can be, so lab tests, unlike rapid tests, the ones that look like home pregnancy tests, tend to be more sophisticated. You don't get the results in minutes. You have to wait a couple days, but it can be blood. It can be capillary blood from the finger, for example. It can be urine, things that are practical to take at a pharmacy. And there has been more innovation in our field in the last 12 months because of COVID than I would say in the prior 12 years. So there are opportunities. And then when you add machine learning, something called next-gen sequencing, where you can sequence DNA much faster and cheaper than you could even a few years ago, there are some extraordinary opportunities for some very accurate and clinically useful tests from simple samples like saliva, capillary blood, and even urine. I hope I've answered.
So you're definitely, again, I'm trying to understand, and you know, the senator is sort of tipping that there are different financial interests, et cetera, but I want to unpack that, but I guess I really want to talk about the way in which certain tests and screenings are done in a doctor's office, for example, versus what it would look like in a pharmacy. Now, you are a lab, or are you a pharmacist? So
no, we are a lab.
You're
we are regulated.
So you're the place where the
right. So this bill.
If I can finish, you're the.
Go ahead.
Hold it. Senator,
let me finish my
your thought.
Thank you. I guess I'm trying to understand, you know, who's advocating. So you are the place where the pharmacist would send the test. You're not the person who's administering. You're not the pharmacist administering the test. The screen.
Correct.
Is that correct?
Yes.
Okay. So maybe the Senate sponsor would, what does it look like in a pharmacy setting to draw blood or to take a urine sample? Because I think that's probably some of what people need to get used to. It's like, it's one thing to have someone, you know, take a little pinprick maybe, or to give me a shot, but there's another setting in which, you know, you're asked to do sort of more personal and somewhat invasive things. So what would it look like? Is there a pharmacist talking about what this would actually look like?
I mean, we have a witness from the you know, the national two pharmacist groups who have testified, but I'd rather let them answer. I think
you want to answer the senator's question?
Yeah. What would it look like?
Sure, Senator Washington. Thank you for your question. And I'll quickly just, I guess, reflect on my test that I actually take at CVS currently for COVID. This test obviously is through a nasal sample, so I stay in my car, and there are different protocols in place to maintain safety. In the pharmacy, when pharmacists are convening going forward with services outside of dispensing, they are to maintain a private room of some sort that adequate for whatever service they are providing. Sometimes it's a closed door, a closed room. Sometimes if it's like a flu shot, there's probably something to demarcate the areas of privacy for the patient. And so, yeah, the pharmacy usually has a specified area to carry out these more private services, if that makes sense. It's not out in the open. There should be room for that.
And is that, and then just, this is a final one, and then we probably have other questions later, but is this part of the adoptions, of the regulations that would be adopted that would require this additional sort of private space? Because I would say that I'm open to this, but again, given the extensive amount of of screenings that is being recommended in this bill, you know, some to me, I think would require that there be a private room and that you're not just doing a, yeah.
Yeah, certainly. And that's something that the Board of Pharmacy can add onto the regulation once they put that forward. Once they promulgate the rules, yeah. So.
Got it. Okay, great. Thank you, Chairman.
Thank you. Senator Ellis, before you go, I'm going to insert a question or two, if you don't mind. I want to follow up with Senator Washington's line of questioning. Look, I like my local pharmacy. It's not a neighborhood, it's a part of a chain, but I'm very happy with it and use it a lot. But that being said, if I were, and Senator, you talked about the opposition being people who worried about their pocketbook. If I were a cynic, I could say that the same could be said of the pharmacies that drive more people into their commercial stores, and for the labs who might increase business. If in fact it was just the lab to shift business, that's one thing, but it could potentially increase lab tests and actually affect cost containment. So how do you respond to that? Both sides have financial interest in this legislation.
Sure. Look, hey, most of the bills in my committee and a lot of bills are about economic self-interest. I'm not here to even, I 100% acknowledge that there's that there. I'm just making a pretty basic point here is right now, our pharmacists, and we saw this year, and I'm going to go back to the HHS secretary and his proclamation giving pharmacists the ability to do COVID testing and now COVID vaccines. That is for a lot of particularly underserved areas and folks without direct care providers, the pharmacist option for screenings, not diagnosis, I'm just saying makes a lot of sense in the post-COVID world where we see the role of pharmacists. So I'm not saying there aren't economic interests involved here. There always are. Again, this committee deals with it all the time. But I guess I see this as a logical, the idea of expanding in some modest way the ability of pharmacists to do certain types of screenings for health, early diagnosis or early prevention diagnoses, or not diagnosis, early prevention screenings, and if necessary, send to a doctor. I think it just makes some sense. So that's not really a direct answer. Yes, there's economic interest. Of course, there's economic interest.
Okay, and final question. I know the Attorney General's office raised it in their letter of information or letter of concern, that the definition is for medical conditions. It's not very narrowly cast. It's
right.
fairly generally cast.
And Mr. Chair, I said at the outset, I would distinguish between some of the folks who I think objection is rooted in economics and that type of objection, which I think is easily rectified with some clarifying amendments. I mean, that definition is loose and it's legit. And I think that could absolutely be tightened up. I think that's a good, totally legitimate point made by the AG.
Thank you, Senator. Senator Ellis.
Yeah, thank you, Mr. Chairman. Thank you, Senator Feldman, for this legislation. I apologize. I came in, I think, in the middle of this hearing. I was at another committee presenting a bill. And so forgive me if this is redundant. I came in on the part where Senator Washington asked about privacy and clinic. And I always was concerned, have been concerned about that. My local chain pharmacy, great pharmacist, great service, but there's no area for any private anything. I mean, flu shots, I get my flu shots there and it's outside of the, customer area, little chair you sit down with everyone walking by and everything like that. As we give more authorizations for pharmacists to do these very much invasive procedures, medical procedures, actually being a provider. I kind of heard what the gentleman, Mr. Abanola, I believe, forgive me if I get that wrong. You said they are supposed to provide a private area. And I know some stores have minute clinics and other clinics that there's a private area, but my chain pharmacy don't have that. And could you just
I mean, I don't know if I can, look, when you say medically invasive, this bill's not designed to do medically invasive procedures. We're talking saliva tests, certain blood and urine, some tests that are not, that would be easy to get a specimen. And, you're right. I can't say I go get a flu shot, they have a room. Everybody's getting COVID testing and vaccines. That's being done at pharmacies right now. So I don't envision that the screenings that we're talking about here are the types of screenings, as Mr. Cohen mentioned, whether it's a saliva for some kind of genetic testing or some PSA testing, through blood draw. I mean, I'm not sure that we're envisioning anything more, but it is different types of screenings for different kinds of early prevention to disease, which we've seen, again, a plummeting over the last year in the nation. So I don't think this bill is envisioning any kind of invasive medical procedures. At least that's not the intent here.
Yeah, when I say invasive, maybe I'm not using the right terminology, but I consider it time someone get inside my personhood, it's invasive, whether it's an injection or have to open any orifice of my body for them to penetrate with any.
Okay, well, I'll defer to the pharmacist, Mr. Cohen, but I don't think that any of the expansion of the scope, the authority here, pharmacists is sort of envisioning what you just described, but I don't think that's say for 100% certainty. But.
No, I'll just briefly add, legit concerns, and I've heard a lot of the same things about referring to chain pharmacies. So your CVS's, your Walgreens, represent independent pharmacies and what I was speaking to. I know I gave the CVS example, but independent community pharmacies, at least the ones I've had the privilege of working in, more times than not have rooms that can be utilized for a confidential pharmacist-patient relationship or testing services or just assessments of drugs and medications and things like that. Most of them do. And again, the Board of Pharmacy will have the authority to put regulations to ensure that privacy is maintained, to ensure that protocols are in place, to also address things like just running a test for no reason. So all those things, I think the language in the bill adequately addresses that. But yes, independent community pharmacies do have rooms, private rooms that they can use when needed to furnish some of these services that you are mentioning, Senator Ellis.
So quick follow-up. You said the board does have or will have the authority to require these procedures to be done in a private area.
Yeah, as written right now, the Board of Pharmacy has to furnish regulations according to the provisions of the bill. And so that's something they can add to that as a concern. And we'll have the chance to voice that as well if and when it gets to that point.
Okay, we're going to move to the opponents. We're going to hear from Elaine Crane, Matt Celentino, and Steve Wise.
Mr. Chair, I may have to bump back to my own committee in a couple of minutes. So if no disrespect, I might have to do that, but I'll stick on a little bit. So
we understand and appreciate it, Senator. Yeah. Ms. Crane.
Thank you, sir. My name is Elaine Crane. I'm representing the Maryland Nurses Association. And I respect the knowledge base and access to care that my pharmacist colleagues do bring to our healthcare system, but ordering isn't really the issue here. Ordering a test, it's dealing with the results that's important. Results of screening and early detection need to be backed, one, by patient information, and providers, not pharmacists, usually have all the information about patients' medical history, family medical history. This takes time to gather. And one pharmacy may not have a complete medication list on a patient because patients may have multiple pharmacies, like a mail order pharmacy, specialty pharmacy, and a local pharmacy. A specialty medication from a specialty pharmacy, if you COVID testing is a big topic in this discussion. It can't really be compared to other testings. Tests at pharmacies and testing centers for COVID are fine for travel needs or contract tracing or for general information. But if a patient is symptomatic, they are usually tested and seen by their provider. The choice is easily made by a patient. But if you use the other example, say of PSA, an elevated level may indicate prostate cancer, but it can also be affected by other things, enlarged prostate, urinary tract infection, and further examination in the history would be needed to appropriately care for that patient and the order and results. So the buzzwords here to remember are fragmented care, or perhaps too many cooks spoil the broth. I'm asking for a non-favorable report on 706.
Thank you, Ms. Crane. Let's have Matt Celentano.
Thank you, Mr. Chairman, members of the committee. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers of Maryland, which is comprised of Aetna, CareFirst, Cigna, Kaiser, and United Healthcare, respectfully opposed to Senate Bill 706. In the bill, first, the definition of health awareness is concerning. It really could mean anything, and if there's a particular issue the proponents want to address, we would suggest they focus the language. It might be the intention of the proponents, but the bill is also not limited to private pay patients as it's written. Since the bill falls into the pharmacist scope of practice under Senate Bill 706, health insurers would have to pay because carriers pay for lab test administration by other healthcare providers. Our contracted providers know how to send lab specimens to labs that we contract with, in-network labs. We don't know how the pharmacists under the bill would have any knowledge about those contracted relationships. And without that knowledge, it could lead to tremendous consumer cost exposure, talking about bending the cost curve in the wrong direction. Lastly, what would happen with the lab results when they go back to the pharmacists? How would they be qualified to discuss results or next steps with the patient? If it's bumped to the primary care physician, why didn't that primary care physician just order the appropriate tests after consultation with the patient in the first place? And also, who consults after? In the case of an uninsured patient, how would a referral to a practitioner be adequate? Who decides which practitioner? How is that element going to be explored? And lastly, who is liable for the patient? Is it the pharmacist now? It's unclear. And there's just too many questions that we don't have the answer to. We urge an unfavorable report on Senate Bill 706. Thank you very much. You're muted, Senator Pinsky.
Mr. Wise, you're on, if you can hear me. Steve, while you don't show being muted, you are. I don't know what you'll have to do.
How's that?
Perfect.
Okay. Thank you, Mr. Chairman, members of the committee. Steve Wise on behalf of MedChi, the community health centers, and several medical specialty organizations. You have our written testimony. I think really 3 points. The principal concern here is that typically when a lab test is ordered, that's done based on the medical judgment of a provider who has done a patient history or exam and determined that certain tests are in order and ruled out that certain tests may not be in order. And the pharmacist does not have that medical training. So you're looking potentially at ordering tests that simply aren't necessary under the circumstances and wouldn't have been ordered if a medical professional had the opportunity to do a complete workup on the patient. I'll note to you that ordering unnecessary tests is such a serious issue in the medical field that in the physician statute, not in regulations to be developed later, in the physician statute, physicians face discipline for not following the standard of care, but also overutilizing healthcare services. That is, ordering too many tests. No such similar disciplinary basis exists in the current pharmacist statute. The third point is, I think it's notable that when the results come back under the bill, the pharmacist is directed to send abnormal results and direct the patient to a primary care provider. I mean, I think that suggests that the pharmacist maybe shouldn't be the first person ordering the test to begin with, because the determination of whether there should have been a test is the first step, but interpreting the results is also, you know, part and parcel to having ordered the test in the first place. Perhaps it wouldn't have been necessary at all to begin with, on my initial point. The final thing I'd say is there was reference to telehealth, and that this is better than a stranger on the internet, I think was the quote. Well, under the state's telehealth laws, if a physician, for example, has seen a patient, they have an obligation under the telehealth statute based on their knowledge to say that person needs to go to an in-person visit. And only the physician or the nurse practitioner has the training to make that assessment, and they're obligated to send that person to an in-person visit. So I don't think that it's better than a physician on the internet. I think that physician brings a lot to bear and has an obligation to tell that person to have an in-person visit when it's appropriate. So for those reasons, we oppose the bill and ask the committee to do the same. Thank you.
Okay, question for the opposition. Obviously, some of the issues came up during the questions for the proponents. Any questions for the opposition? Seeing none, Senator Feldman, thanks for bringing the bill to EHE, and you can head back to finance. We're going to go to Senator Augustine, 736, Pharmacists Administration of Vaccinations. Senator Augustine will be followed by Sandra Guckian, Kaylee Locklear, Olamide Banjo, and Aaliyah Horton. Then we'll take questions, and then we'll go to the unfavorables, Sarah Cusack, Susan Chadovitz, Joe Fitzgerald, and Pam Casemeyer. Welcome to EHE, Senator Augustine.
Thank you, Chair Pinsky, Vice Chair. I don't see her here. And members of the committee. Senator Malcolm Augustine here on behalf of Senate Bill 736, which will authorize a pharmacist to administer vaccinations approved by the FDA to an individual who is at least 3 years old, but under the age of 18, and that will remove other barriers to access to vaccinations. Members of the committee, I'm really pleased that I got a chance to hear the testimony of the bill before us, because it really sets the stage quite nicely for this bill. This bill talks about all that you just heard, but is more specific to vaccinations. And these are vaccinations that are currently already occurring at pharmacies across the state of Maryland. And they are being done with success. In August of last year, the U.S. Food and Drug Administration, in conjunction with the CDC, authorized the pharmacies to provide these services. In fact, and I'm sure that you guys received, there was a letter from the AG which clarified that, and then they talked about how these were already authorized and were already occurring in Maryland based on the federal and the state orders that were issued. And one thing that I did want to share with you all, along with the lines of that letter, is that it was the intent, and we worked with the bill drafters on this legislation to make sure that this legislation, in fact, did mirror the federal order and state orders, so that it would be consistent with what is currently going on. And if we need to fix it along those lines, more than happy to do so. It was our intent all along for it to be the case. The question is, like, why? Why do we need this bill? Why do we need it? Well, we need it because in the midst of this pandemic, what we've learned is that there is a real gap. I mean, this is something that we already knew, but there's a tremendous gap. There's a hole, like we heard in the previous panel, of service, of access to service. Critical services, including vaccinations, for our children. In fact, the senators talked about in the rural communities, it implies the rural and the urban communities that 45% of our children do not have a medical home. 45%. And so I think it's very important for us to keep in mind that the pharmacy in some ways is that home. And it is a place where they can actually receive the vaccinations that they need in a place that's close, accessible, doesn't force their parents to have to take time off of work, allows them to continue to do the kinds of things that they need to do in their lives. And so I think that those things are extremely important. I think it's also just important to keep in mind, folks, that while we are now living in Maryland with this existing situation, that has not been the case across the country. In fact, there are many states that already allow for this level of immunization, 11 states that don't have an age requirement at all, and 30 who have different levels of immunization. Of course, we already allow, with certain restrictions for pharmacists to provide the flu vaccine. Our pharmacists know how to do this. They have been doing it, and they have been able to provide vaccine services in a way that is safe, but increases access for our kids. This is a particularly acute situation right now, given the fact that our departments of health, and it doesn't appear to be any end in sight to this, are so consumed, and rightfully so, with the issues and concerns of COVID and different strains and future things like that, that they can't be there for our kids for other vaccines. So where can the kids go if the departments of health are actually not open? They can go to the pharmacies. That's where they can go. They can go to those places that are in their communities, that are local, and that can provide them with the services that they need. And that's what the pharmacies are able to do. And that's what this bill tries to do, is it tries to create a better access point for our kids. And I just want to remind you all that there are already a built-in track record of this in Maryland. I mean, the pharmacies have been providing vaccines to 18-plus-year-olds since 2006. They've been providing other vaccines at ARCS since 2011. And going back to like 2017, they provided over 266,000 vaccines to patients in Maryland. And that was just the flu shots. I mean, this is not something that is novel. This is something that they have the ability to do, and to do so safely. There are other safeguards that are in place. They must provide vaccine information statements to provide educational background. And we know that this legislature and this body has Immunet, which stores the individual vaccine history, and they are the ones who are updating that so that there is a complete record for the of children's vaccinations that's available, that becomes available to others so that they can utilize it for other matters. Now, this bill, really will provide over 1,200 additional locations that Marylanders with their kids can visit anytime to fulfill their immunization requirements. And we haven't talked about it, but I talked with you guys about this last year. It also would include things like those travel immunizations. We have a significant immigrant community in Maryland who also needs ready access to immunizations of these types. And the pharmacies are the place to do that. And so members of the committee, I asked for a favorable report on Senate Bill 736, and I'm open to answer any questions that you might have.
Thank you, Senator. If you can stick around, let's hear from the other proponents, and we'll take all the questions at once, if that's okay with you.
Absolutely.
Let's go to Sandra Guckian, NACDS, followed by Kaylee Locklear with the retailers, followed by Olamija Banjo, followed by Aaliyah Horton.
Good afternoon, Chair Pinsky and members of the Education, Health, and Environment Affairs Committee. My name is Sandra Guckian. I'm a pharmacist, and I currently serve as Vice President of Health Policy and Pharmacy Care with the National Association of Chain Drugstores. Thank you for this opportunity to speak in support of Senate Bill 736 that would expand access to childhood vaccines in pharmacies across the state. Nationally, with 90% of Americans living within 5 miles of their neighborhood pharmacy, community pharmacies are able to serve patients at multiple locations with extended evening and weekend hours, thus offering an unparalleled opportunity for access to pharmacy care services. In August of last year, the U.S. Department of Health and Human Services recognized the adverse impact that coronavirus was having on our healthcare system. They also recognized the qualifications and experience of pharmacist vaccinators. With the third amendment to the Federal PrEP Act, the Department of Health and Human Services declaration superseded state laws and authorized pharmacists and pharmacy interns to order and administer any ACIP recommended vaccine to children ages 3 years and older. Following this, the Maryland Department of Health recognized both the substance of the amendment and its preemption of state law and allows pharmacies to administer childhood vaccinations. However, further action is needed to expand this authority permanently. Well before the current pandemic and prior to the PrEP Act, pharmacy-based immunizations were a well-established practice not only in Maryland, but also nationwide. Since 2015, Maryland pharmacies have administered more than 3 million vaccines to Marylanders, including children and adolescents. Given the severity of the coronavirus and the virus's continuous strain on our healthcare system, now is the time to fully utilize the skill set of pharmacists to deliver quality, accessible patient care and support the larger healthcare team. Pharmacies have well-established protocols in place to ensure the patient is a good candidate for the vaccine that they are seeking. As standard of practice and per Maryland law, pharmacies collect physician contact information from patients and must make at least one attempt to notify the physician when one of their patients has been vaccinated. This notification gives the physician a unique opportunity to reconnect with that patient. And also, as Senator Augustine mentioned, pharmacies also report to the state's registry, which is referred to as Immunet. When pharmacists provide immunization services, they use standard patient questionnaires and screening tools, and they follow the same evidence-based guidelines and protocols of other healthcare providers who also offer vaccine services. For example, our protocols would not allow us to provide a vaccine to a seriously ill patient or a patient with a condition that makes the vaccine ill-advised or unadvisable. Community pharmacies present places that many individuals feel very comfortable coming to for vaccine services. Patients tend to see their pharmacist many more times per year than their other healthcare providers. And additionally, pharmacists can help bridge gaps in care by communicating with the patient's primary care provider, offering referrals, and also counseling patients on the importance of both routine and follow-up medical care, and also most importantly, educating parents about the importance of well child visits. In closing, we urge the committee to pass this bill to expand access to childhood vaccines in community pharmacies across the state. NECDS extends our appreciation to Senator Augustine, Chair Pinsky, and all the members of the committee for recognizing the opportunity to offer patients expanded access to vaccine services in community pharmacies across the state. Thank you for your time.
Thank you, Ms. Guckian. Ms. Locklear, you're up next.
Good afternoon, Chair Pinsky and honorable members of the committee. Kaylee Locklear for the record here on behalf of the Maryland Chain Drug Store Association in strong support of this legislation. So you've heard some of this already. We as pharmacists already have state authority, which the legislature passed with a prescription for a child aged 11 and up. Plus, we now have 7 months of federal authority to immunize children 3 and above. And not to mention that this has been common practice, as Senator Augustine talked about, in the majority of states prior to the pandemic. Per the fiscal note, the CDC found that routine childhood immunizations fell sharply in 2020 as physician offices were closed. But a quick Google search shows the situation has never resolved. And even prior to COVID, and I think most importantly, according to a Kaiser study, 45% of children in Maryland do not have a medical home. Many do not have a primary care doctor or a pediatrician, period. These children and their families have been reliant on health department vaccine clinics that now have been closed in some of our counties due to the focus on COVID, or have severely limited hours, most by appointment only. This bill is and continues to be about access and the cost of healthcare. Pharmacists complement the work of other healthcare providers, bringing the cost of immunizations down, and their access over time has shown to improve vaccine rates. Maryland pharmacists have been immunizing children down to the age of 3 safely for the past 7 months in Maryland without issue. But in other states, it's been going on for years, and we urge the committee to make this permanent. Thank you.
Thank you, Ms. Locklear. Ms. Banjo.
Good afternoon, everyone. Thanks for giving me the opportunity to give a statement here today. Really just in support of everything that has been said. I want to really highlight our pharmacist education. As a pharmacist, I've been practicing for 15 years. I've had the opportunity and the fortune of practicing in several different states, holding licensure in different states, including to our neighboring jurisdictions here, as well as having the opportunity to work in several different settings with pediatric populations, and most recently as a clinical coordinator. And I'll tell you, pharmacists, more so than other healthcare providers, have worked with people across the age spectrum. We've got, experience working with our older patients. We have experience working with our younger patients. It's really been highlighted the level of accessibility that pharmacists provide to patients. As a pharmacist, we go through a rigorous training program. We go through 6 years that focuses greatly on patient assessment, screening, and direct patient care. And in some cases, such as myself, we have pharmacists that do have an advanced, practice training. And I really want to highlight on that patient care piece, because this is really what it comes down to, which is providing this level of access, providing this level of care for our younger patients. We are the medication experts. We have done an inordinate amount of, immunizations in pediatric populations since the HHS ruling came into place. And what we want to see is that progress continuing. We're able to identify any kind of missed opportunities when those patients come to us, when the parents and guardians come to us and we're having those conversations. We are able to really highlight and figure out what is it that our patients need. Not only do we look at our patients' medication therapy, but we also look at preventative care, and we take a look at our patients holistically. So essentially, what is it that they, based on their age, based on their disease states, based on their medications, what is it that they need, and how can we fill those gaps? It's also been mentioned our hours of operation. These are very well suited to busy parents. Even with, with the pandemic that's going on, people's lifestyles have changed. There have been upheavals. Personally, as a parent of a 3 and a 5-year-old, I'll tell you, I had a telehealth visit with their physician this morning, and things change, and it's really just about creating, again, those greater, levels, access of care. And then really just in conclusion, I want to really talk about our underserved communities and communities of color, and really providing this service to them as well.
Ms. Banjo, thank you. Okay, is Ms. Horton with us?
Mr. Chairman, she had a family emergency and cannot join us.
Okay, then let's take questions for the proponents before we move on to the opponents. Let me ask one very quickly. Senator Augustine, I don't know if you had an opportunity to read the Attorney General's comments. He thought that the way the bill is drafted, it goes beyond the federal and state orders currently in place and expanded it, which he felt uncomfortable about. And he suggested if it continued the current orders at the federal and state level to December 2022. Is that acceptable, or do you think that defeats the bill?
Well, as I said, we felt that the we tried to draft it in keeping with the federal regulation. So that part's fine, right? I mean, we wanted it to be in keeping with that. So if they feel like there's some drafting language that we need to fix in order for it to be in keeping with that, then that makes a lot of sense.
Well, it does narrow it because currently the bill says FDA approved, which is a broader universe than those described in the federal and state orders. That's the only difference as far as I understand it.
Yeah, like I said, as Kaylee, if she would like to jump in on that too, I was comfortable with that. I mean, Kaylee, I don't know if you wanted to comment on that, and then.
See, I'd ask Sandra to talk about it real quick because we did see the Attorney General's letter, and Sandra can answer, I think, some of those questions real quick, Mr. Chairman.
Okay, we only have a couple hours and we have a lot of bills, so we really have to be concise. Ms. Guckian.
You're on mute.
Ma'am.
I'd like to echo Senator Augustine's comments earlier. He had talked about the importance of international travel and that being a component here to be addressed and discussed. So maybe that's something perhaps that requires further conversation beyond our time today and something that we could discuss.
That's an important question. I mean, obviously under FDA approved, it's Ebola, it's a number of other diseases. We should talk offline of how narrow or broad and what opposition there'll be. So we'll continue that conversation. Okay, let's go to the opponents if we can. I have Susan Chadovitz, Joe Fitzgerald, Pam Casemeyer, and Sarah Cusack.
Good afternoon. My name is Dr. Susan Chadovitz. I'm a practicing pediatrician and representing the Maryland chapter of the American Academy of Pediatrics. I'm speaking in strong opposition to Senate Bill 736. While many families see the 4 to 5-year-old visit as a routine quote unquote shot visit and may be inclined to get their shots at a pharmacist and skip the visit, child advocates recognize that the 4 and 5-year visit are a comprehensive opportunity for surveillance and screening. The visit is primarily an assessment of school readiness. At these visits, children are screened for hearing and vision problems, and pediatric providers assess speech and cognitive functioning, social skills, and emotional and behavioral strengths and concerns. If concerns are identified, we refer for developmental assessments, early intervention services, mental health services, and Head Start or other preschool opportunities. This assessment and referral process in the year before school, before children start kindergarten, is an essential step in assuring school readiness. We can communicate concerns with the school system and start an individual educational plan if indicated. This optimizes a successful transition to school. We often speak of the importance of early intervention and school readiness, but Senate Bill 736 would just directly dismantle a piece of that system that works to support children as they start school by allowing children to skip the routine healthcare exam and simply get shots. This is done in the name of increasing access to immunizations, but Maryland has an excellent immunization rate. I firmly believe this bill would do more harm to children than it would help them. It would be unfortunate if the COVID pandemic was used as an excuse to fragment healthcare delivered to children. There's been mention of the Kaiser study that shows that 45% of Marylanders don't have a medical home. The study was not that they don't have a doctor or a place to get care. It was a medical home, which is a much more comprehensive definition of care. So I don't think we can say that that means children don't have a place to get care. If access is a concern, pediatricians would be happy to see the state support an increasing capacity of our local health departments to immunize children who lack a usual source of care. The local health departments are skilled at assessing barriers and helping families access insurance and connect with the usual source of care. This would be completely lost if vaccines were delivered at pharmacies. Thank you very much for your time.
Thank you, Ms. Chadovitz. Let's go to Joe Fitzgerald and Ms. Fitzgerald. You need to unmute, ma'am.
There we go. Hi, good afternoon, Chair, Vice Chair, and the members of this committee. Thank you for allowing me this opportunity to testify today. I am a registered nurse and a grandmother, So this bill could possibly impact my 3 grandchildren. Since pharmacies have started giving the flu vaccine, there has been a tremendous increase in shoulder injuries due to inappropriate placement of the needle, which has resulted in damage to the ligaments, tendons, and nerves, causing a lifelong injury such as paralysis and chronic pain to the upper extremity. If this injury is happening to adults who are willing participants, what is going to happen to a child who is not a willing participant, who is uncooperative, wiggles around, and is sometimes screaming, many times requiring to be restrained by 1 or more individuals to give an injection? I have my own personal experience with my own child who did pass out after a vaccine. As my 5-year-old came off the exam table, he passed out, fell over, knocking his 3-year-old brother to the floor, and it appeared that the 3-year-old may have broken his leg because he was kind of like chopped blocked from the side. Meanwhile, my 5-year-old was passed out on the floor while my 3-year-old was screaming and crying. It took 40 minutes just to recover my 5-year-old's blood pressure, but we were still in the office for almost 2 hours. During this time, the doctor had to consistently monitor the 5-year-old and try to bring his blood pressure up, at the same time assessing my 3-year-old's leg to see if it was possibly broken. Fortunately, I was in the doctor's office with the doctor and the other medical staff, support staff, because in an instant, we had 2 emergency type situations going on. I can't even imagine this happening at a Walmart. I don't even know what they would do. I'm assuming they would just call 911. Pharmacies are not set up with private rooms with the necessary medical equipment that may be necessary for an emergency situation. I also cannot emphasize enough the importance of the physician's assessment directly prior to giving an invasive medical procedure. This is why we have pediatricians. They specialize in assessing children and the appropriateness of receiving a vaccine listed on the CDC recommended vaccine schedule.
Thank you, Ms.
Fitzgerald. To this bill, and thank you for taking my consideration.
Thank you. Again, committee members and others, we have 9 bills and 2 hours and 50 minutes before we go back in the session. We could reconvene after 8 o'clock if we don't complete our bills. Ms. Casemeyer, followed by Ms. Cusack.
Mr. Chairman, members of the committee, Pam Casemeyer, I'll try to be brief. Dr. Chadovitz did a terrific job. I'm here on behalf of the Medical Society, the community health centers, and other physician specialties to reiterate much of what you've heard. The concern is, we understand during the COVID crisis, we've had a lot of relaxation of a lot of standards because it's a unique situation. But to make that permanent going forward has a lot of potential unintended consequences. As you've heard, Maryland has one of the highest vaccination rates in the country. So it isn't as if our numbers are not good. They've been in the 90% range consistently. But what we're doing here is basically eliminating the well child visits that Dr. Chadovitz talked about, but also not only this well child visits at the younger ages, but you're taking away the prescription for those from 11 to 18, as it is now in law. When you think about adolescents and their visits at times with their providers, that's often when they share issues about behavioral health challenges and other things, trauma-informed, adverse childhood experiences, things they're experiencing that maybe they can't share with anyone else but their physician. So dismantling that connection for broader healthcare in the younger population has a lot of potential unintended consequences far beyond vaccination rates or vaccines. Not that vaccines aren't critical. We're some of the largest proponents of vaccination, but really do believe in that this is not a wise bifurcation of care. And the last issue is Immunet. Immunet is a very good platform, but it still has a tremendous amount of technical problems. People will enter vaccines later on, not be able to find that they are in the system. So to assume that just because there's Immunet, a provider would know whether someone had already had the vaccine is not an accurate assumption. It is not a perfect database. So for a number of reasons, and to save your time, we're here strongly opposed to this legislation and believe that it's a problem or a solution in search of a problem at this juncture.
Thank you. Ms. Cusack, please.
Thank you, committee members, for allowing me to testify today. My main concern with this bill is regarding examination and assessment. I don't understand how a pharmacist will know which vaccines are appropriate for a child. The CDC recommended schedule is not a checklist. It is a recommendation that was always to be paired with examination and assessment, like what children get with a well visit with their pediatrician. 4-year-old children who would be affected by this bill, according to the CDC recommendations, are to be vaccinated for measles, mumps, rubella, chickenpox, diphtheria, tetanus, pertussis, polio, and influenza. This is not appropriate for all children. I have a child with an autoimmune condition. Her pediatrician would never give all of these in a single visit. She can't handle it. So this bill does not specify that pharmacists would only be vaccinating perfectly healthy children. We have children today with multiple allergies, cancer diagnosis, autoimmune diagnoses. We have children who have had prior adverse reactions to vaccines, passing out, seizures, anaphylaxis. You need to consider that children may have their first adverse reaction to a vaccine in a pharmacy. I put in my written testimony, I reached out to a pharmacist friend of mine because I am a pediatric physical therapist. I know what it's like to work with peds. I asked her about the bill and she said, Sarah, I have to tell you, not all pharmacists like children. And what she meant is they're not going to have the patience or the skill set. They didn't sign up to do direct patient care or pediatrics. So I'm very concerned to imagine, you know, CDC recommends a thin 3-year-old needs to be vaccinated in their thighs. So I'm just trying to imagine a 3-year-old in a crowded Walmart or Target with their pants pulled down or their shirt off, screaming, and how this is all going to be handled. I just think it's inappropriate for kids. Thank you.
Thank you. Seeing no questions, that concludes the hearing on Senator Augustine's bill on pharmacists. Thank you, Senator.
Thank you, Chair Pensky.
Testifying. Again, except for the sponsor, we're going to go to a 2-minute time limit because I don't want to bring people back after 8 o'clock. We're going to go to Senator Eckert. There's no opposition. She's going to be followed by Karen Evans, Certified Nursing Assistant Advisory Committee. Welcome, Senator Eckert. This bill will be followed by Senator Alfred. Please.
Thank you. Thank you very much, Mr. Chairman, Madam Vice Chair, and members of the Education, Health, and Environmental Affairs Committee. I appreciate the opportunity to be here with you to present Senate Bill 744. Just to give you a little history, I've been working with how we get more CNAs into the workplace. This has been exacerbated because of the COVID crisis, as you know, and I'm very concerned about entry into nursing practice and getting more health professionals through the ranks, as you can imagine, and then how we expedite our CNAs in the workplace. So working with the Board of Nursing, we found that there is a nursing advisory committee that evaluates and makes recommendation to the full Board of Nursing regarding training programs, regulation, and enforcement. In addition, this advisory committee evaluates candidates and reviews investigations of complaints against nursing assistants or med techs and makes recommendations for disciplinary action. So this bill actually conforms the language regarding membership and meeting requirements for the State Board of Nursing Advisory Committee to be in line with other Board of Nursing subcommittees. As the Board of Nursing continues to be on the forefront of healthcare delivery in the state, Senate Bill 744 establishes consistency in the statute governing their makeup, and I think will really propel this whole entry into practice with CNAs and oversight of some of the modifications that we've made in other pieces of legislation, more a real impetus to practice. So thank you for your consideration. I expect a favorable report, and I'll turn it over to Karen Evans from the Board of Nursing. Thank you all very much.
Thanks.
Ms. Evans, please.
Thank you, Senator Eckhart and Chairman Penske and the members of this committee. Thank you for allowing me to testify today in favor of this legislation. This will get this particular committee in line with all of our others so that we can be fair, but this committee is near and dear to my heart as well because of the entry level of all of our CNAs as well as certified medicine aides, med tech. This particular committee covers all of those particular certification holders. So in order and in line with other legislation that has gone forth concerning refresher courses for these entities, this would be, I'm asked for a favorable report from this committee. And thank you for, Senator Eckert said it all. So thank you very much for allowing me to testify today.
Thanks for joining us, Ms. Evans. Questions for Senator Eckert or Ms. Evans? Seeing none and there not being opposition, that concludes the hearing on that bill. Thank you, Senator.
Thank you.
Thank you.
Now we're going to go to Senate Bill 745. Senator Alfred, State Board of Massage Therapist Examiners revisions. Senator Alfred will be followed by Caitlin Thompson and Amelia Mitchell. And I also do not see any oral or written opposition to the bill. Senator Alfred.
Thank you, Mr. Chair. Thank you, members of the committee. I'll try to be brief. For the record, Senator Sarah Alfred, representing Maryland's District 30, here to present Senate Bill 745. This really came to me at the request of the State Board of Massage Therapists, Therapy Examiners, rather. Their code, despite advances in their practice, has not been updated in quite some time. So this bill, I think, is relatively straightforward. It's updating a couple of key provisions in the law, including a standardization of the curriculum for massage students across the state, modernizing the criminal background check process, removing some outdated terms that are just no longer really in use, replacing the CDC guidelines on universal precautions with the correctly named CDC guidelines on standard precautions, and lastly, eliminating some unnecessary language regarding insurance coverage. Mr. Chair, I think that's as straightforward as I can possibly be. I know my panelists are the experts here and I will rely on them, but I request a favorable report of Senate Bill 745. Thank you.
Thank you, Senator. Ms. Thompson, welcome.
Hello, thank you, Senator Pinsky, so much. Thank you to this committee for hearing our Bill 745. We hope for a favorable review from you. I'm the chair of the State Board of Massage Therapy Examiners. Our purpose is to regulate and govern and protect the public, and I believe that every one of the finer points of this bill does exactly that. Modernizing the language to make it more clear to massage lay people, including legislators and the public. By introducing a CompTIA-approved curriculum, we are advancing our educational requirements without placing any undue financial burden on potential registrants. By updating and making more accessible the criminal background report, it obviously makes it much easier for us to protect the public. The inactive portion was simply missing. Our board is fairly new, and that was actually just missing from our original statute, so it needed to be put into place. And obviously the insurance coverage is outdated. So I thank you very much. Thank you very much to AMTA Maryland, our trade association, for working so very hard on this bill. We've been working in strong collaboration together, and we look for a favorable report from the committee. Thank you so much for your time.
Thank you, Ms. Thompson. Questions for Senator Alfred or Ms. Thompson? Simon Air.
Thank you. Senator Alfred, nice to see you again.
Favorite committee, I promise.
No problem. Just a couple quick questions.
Okay.
Over the last couple of years, I've actually had got involved with massage therapy requirements and so forth. I'm sure this is fine. I noticed that you're removing the part that says they have to be fully clothed, but I understand where that's coming from. But to my real point, from what I understand, at least from the community college standpoint and from the fiscal note, you have the LMT, which is the licensed massage therapist, and then the RMP, which is registered massage therapy practitioner. And one can practice in healthcare, like a chiropractor or places like that, but the other one may not. I believe Maryland's the only state that does that. And so I looked up the requirements difference, and there's only one course that they have. It's only 4 credits that distinguishes the two, other than the English or math or someone would take with associate's degree. And I guess I'm wondering, you know, I know this isn't the intent of your bill, but we're looking at this now. Why is Maryland doing it that way? So someone who is basically trained in the exact same manner, you know, it may be a chiropractor that they want to give a massage, but the way the current law is set up, they can't go into a chiropractor's office simply because they had this one other course. And, you know, would you consider or discuss, you know, maybe putting that one course in the certificate program so they could do that? Because other states are doing this, it makes it, I don't know if it's a turf battle or what. I'm not really sure where it's come from.
Yep.
But I've talked to people that have gotten licenses outside the state because of that very thing. They get their certificate here in Maryland, and then they go practice in Virginia for that very reason, or other states. So if you could just give me some info.
I'm happy to speak to that. Our board has actually voted to proceed with changing our 2-tiered system to a 1-tier system. So that project is definitely on the horizon. Obviously, there's a lot of working parts there. But we expect to have legislation in the next legislative year for that. We've actually just voted in the past few months we've been a 2-tier system since our inception. So it's going to be a lot of working parts, but absolutely, your concerns are very well received with this board. So we are taking steps in that direction. This bill that we're talking about right now is just sort of cleaning up the language that we have that's sort of not fitting with what we have existing.
Okay, that's great. And then while you're looking into that next year, if you would also look into the retroactive portion where people have already graduated and they don't have that one course that they could now get that course.
We have already come up with some solutions to that. Thank you.
I'll look forward to it. Thank you.
Thank you.
Thank you.
I apologize, Ms. Mitchell. I missed her as a proponent. I apologize, Ms. Mitchell, if you want to take a minute or two to add anything. Again, there's no opposition to the bill.
Absolutely. Thank you, Senator Pinsky and committee. My name is Amelia Mitchell. I am a licensed massage therapist and a board member with the American Massage Therapy Association, the Maryland chapter. And we are also here asking for your support of SB 745. The Department of Health has licensed or registered those who practice massage therapy for over 20 years. There are 4,000 professionals currently under their authority. During that time, it's simple. Language, technology, and information access has simply shifted. And this bill is about modernization of language. There are a lot of things, as Ms. Thompson just discussed, about the 1-tier system that we're looking at going forward. This bill simply gets some things in place neatly so we can continue to work to improve how massage therapy functions in Maryland. So we are very much aligned with modernizing the criminal background check system. Adding the CompTIA approved curriculum simply makes sense because this is a massage specific curriculum that is recognized around the country, and asking all of the Maryland schools to meet this minimum level of curriculum means that massage students of the future can be assured that they are getting a quality massage education that will prepare them to take their licensure exams and become a therapist. At the same time, it also assures the state board that the new therapists are actually qualified. The other little details, the definitions, outdated terms. We don't need to speak French to discuss massage these days. So this is simply cleaning up some pieces and bringing us all up to the 21st century. We have worked on all of this in collaboration with the state board, and AMTA Maryland, the American Massage Therapy Association, asks for a favorable report on this bill. Thank you.
Thank you. Questions? Seeing none. That concludes the hearing on that bill. Thank you all for your testimony, your patience.
Thank you, Mr. Chair.
I'm going to have the vice chair take Senator Hayes if he has joined us. He has a couple witnesses who are also limited in time.
All right.
Is Senator Hayes here?
He's not on, and I didn't get the word that he was going early.
I just texted him.
I wasn't able to contact him.
I know I see you, Senator McCray. Let's give him 15 or 20 seconds. If he gets on, fine. If not, we'll
Senator
Edwards around since he has a quick bill?
I'm sorry?
He's not either.
Senator
No.
McCray, I know you're
No.
here. You've got a bunch of folks. Okay.
Yeah.
Let me try and get Hayes really quick again.
I texted him.
Okay.
We'll wait 15 or 20 seconds, Madam Chair, and if not, then just go on to the other bill.
Will do.
Okay.
Mr. McCray, Senator McCray, we're happy you're here, so. Okay, so should we go to Senator McCray?
Okay.
Okay. Lamaria, if Senator Hayes comes in, you can tell him that that we tried. Senator McCray has Senate Bill 762. We're delighted that you're back in EHE. Now, as the chairman has been saying, we still have a lot of bills and the Senate is going back into session at 6 o'clock. Since there are no opponents, you will win a lot of love from this committee if you and your witnesses can be super abbreviated. Tell us about the bill, make your case, but you don't need to use all of your time. But we're going to kick off with you, Senator McCray, followed by Jack Wilson from JTW Building Services, then Grant Schmelzer, Pete Demchuk, David Murray, and Bruce Bariano. And let's see, David Kiddo is here as well. That is too many. I will figure that out, but let's start with Senator McCray. Welcome back to EHE.
Thank you, Madam Chair. And I thought that I was abbreviated with all my bills, but I'll try my best even better with this one. Committee, I'm here on behalf of Senate Bill 762, which is the Maryland Electricians bill for just licensure. This bill has come before this committee before, so I'll be somewhat brief. This bill came before the committee last year, and it was the posture of the committee to have it work group. This bill was work group through the Maryland Department of Labor leading that effort, and there was some consensus that was able to be met with this bill, and there was only one standing issue that couldn't be met at that time, so we left that part of the bill out, and I actually got a recommendation to put forward that the part that could not be figured out was the low voltage piece of it. And what the analyst's recommendation was to put inside of the bill that it will be dealt with at a later time. And that's what you see how the bill is. There was a amendment that was put forward where I guess the low voltage folks don't want it done through regulation. They would like to have it done through a work group if it couldn't be passed into some form of a law. And I don't have a problem with that recommendation. This is the first time that MACO has ever been supportive of this bill. So I would take notice of that our local jurisdictions, that this bill is in a posture where our local jurisdictions can be supportive of this bill. I would also like to say to the committee that this is not the first year, this is not the second year, but this bill has been heard for more than a decade, and there have been people that have led this effort. And I would just like to say, i.e. Senator Klossmeyer, who has taken this on, and she's just passed it my way only because I am an electrician. I'm here today, Madam Chair, with 3 other people who have passionately worked vigilantly on this over the years: Jack Wilson, Pete Demchuk, and Grant Smeltzer, who will also due diligence in reference to saying why this bill is important for not just Marylanders, electricians, but also our economy. Thank you again. Hope I was brief.
Senator McCray, you're awesome, as always. It's always good to have you here. Thank you. Mr. Wilson, thank you for your hard work on this bill. You do have extra up to 5 minutes, but again, there is no opposition. So if you can be a little abbreviated, we'd be grateful. You may begin.
I will be as brief as possible. Good afternoon, Madam Chair, committee members, and thank you for the opportunity to speak today in favor of Senate Bill 762. I wear a lot of hats where I could speak to this bill as a county commissioner, as the state board chair, but today I'm here to speak on it as an advocate of it for a long time and a business owner. The bill you're considering has gone through many iterations over the last 10 plus years, as the senator mentioned, from being way too much to not enough. I believe Senate Bill 762 is just the right mix to address the concerns that have been, quite frankly, exhausting over the last 4 years in particular. The bill maintains local jurisdictions' enforcement, permitting, and the ability to maintain revenues. It will provide a consistency in licensing that already exists in our other 2 mechanical trades. It'll provide portability to many electricians, which is limited now. It'll reduce individual master's license costs for licensing and continuing education. It will force out-of-state contractors to compete on an even playing field with our Maryland contractors, keeping millions of dollars right here in Maryland. Increased contractor revenue equals increased tax revenue. It will also create a consistency with our wage scale jobs, ensuring that qualified electricians are working on our public sector projects. It will bring us into alignment with our border states, allowing us to flip the script and open up new markets outside of Maryland. It will also establish a clear-cut career path to licensure for our students who are looking for alternatives to college. When I talked to Senator McCray about speaking today, I had a million things run through my mind I could have said, but there just wasn't enough time, and we're running up against it now. So I just tried to highlight some of the items I felt were most important, and I will be glad to answer any specific questions. And I hope that 762 moves forward with the committee's support. Thank you.
Props to you, Mr. Wilson. Thank you so much. Next up, Grant Schmelzer, IEC Chesapeake. You have up to
Thank you, Madam Chair, committee members. This has been a long time coming. We finally gotten most people all on the same page. I've been around since this was started under Senator Klausmeier. We've had a couple of near hits, but this is the year to bring it home, so to speak. As Senator McCray mentioned, we got Mako on board. I can tell you right after me is going to be a member of the IBEW. So we have the Merit Shop and Union on board on this. As the largest 4-year apprenticeship program in the state of Maryland with more than 900 apprentices now, this is going to be a tremendous tool in ensuring career pathway models. Currently, we're running programming in Howard County Public Schools, Anne Arundel County Public Schools. We've just started programming in Charles County Public Schools and Montgomery County Public Schools. We're slated to start Prince George's County Public Schools and Calvert County Schools in the 21-22 school year. And what our young people want to know is, how do they become a master electrician? And this will ensure a systematic approach so that it's not different in every county that you go. It's standardized, and it'll enable our young people to see how to get the keys to the castle and start their own business if that's the way they choose. So as mentioned, IEC would welcome a favorable review of this committee. And I'm happy to answer any questions, but because of time, I'll limit this to my remarks. Thank you.
Thank you so much, Mr. Schmelzer. Good job. Pete Demchuk with IBEW Local 24. Welcome to EHE.
Good afternoon, Madam Chair and committee members. Thank you for your time and attention to allow me to speak and encourage a favorable vote on Senate Bill 762, the Maryland Electricians Act. Just a little bit of history. I'm a 41-year member of the International Brotherhood of Electrical Workers. I worked out in the field for approximately 30 years there. I've seen a lot of very good electrical work, but I've seen a lot of really bad electrical work. I'm going to skip over a lot of my jobs that I worked on and whatnot and try to cut to my message and the message in the presence of time. I just like to say that I've run across a lot of work that was truly dangerous and a fire hazard with no requirement for licensure here in the state. I think feeds that problem. And like in the name of time, I just ask that the committee gives a favorable report on this bill. Thank you.
Thank you so much, Mr. Demcha. Appreciate it. Next, we're going to hear from David Kiddo, and then we will hear from Bruce Mariano, followed by David Murray. So, Mr. Kiddo, sorry.
Yeah, thanks, Vice Chair Kagan. I appreciate it. Can you hear me okay?
Yep, we sure can.
Super. The Communications Cable and Connectivity Association represents manufacturers and suppliers of information technologies, the infrastructure that supports the robust growth of smart and sustainable communities for our future. These critical systems of cabling and equipment are specified and safely plugged in and programmed by low energy integrators. This is a very different trade from the skills required of licensed electricians who are making direct connections to the higher voltage electrical grid. I'm also speaking consistently on behalf of a vast majority of our connected technologies trade group. In fact, you'll likely note in the written testimony records that the same favorable with amendment position is being taken by multiple stakeholders. The amendment proposal has been entered into the record by CCCA and several others. We do very much favor the bill's objective for statewide licensure for electricians in Maryland. We feel this will be an effective way to expand job opportunities across counties and adjacent states. However, as written, the bill provides unintended consequences if enacted as is, particularly for low voltage integrators. We simply need to provide the clarity and the good delineation for the work of low voltage electricians and integrators, low energy integrators, forgive me. We appreciate the exclusion that was attempted in this master's electrician's license bill. The language provided creates some confusion on the effective line between our different trades. The proposed amendment provides a clear and concise definition for low energy integrators with the clause 6-101. We also want to be clear that we support the continuation of licensing and registration of low energy integrators at the local level as you move forward for statewide electrician licensure. Status quo, if you will, for integrators. We look forward to working with you and the legislature for limited energy services trade legislation going forward. Clause 6-104 in the amendment.
I'm afraid your time has expired. If you could wrap, please.
Okay. In conclusion, we feel that this will help define the differences between the two trade disciplines, and we ask the support to include this amendment.
Thank you so much. Appreciate. Bruce Mariano is up next on behalf of the Alliance for Construction Excellence. Mr. Mariano, welcome to EHE.
Madam Vice Chair and members of the committee, it's a pleasure to be here. On behalf of ACE, which is a specialty construction association, the National Electrical Contractors Association is part of ACE. We very strongly support this legislation. I compliment everyone that's worked on this for many, many years, and a big mazel tov to everybody. Thank you. Would urge a favorable vote.
Love your succinctness. Thank you, Mr. Mariano. Favorable with amendments, David Murray, the Chesapeake Solar and Storage Association. Good to see you, Mr. Murray.
Thank you, Madam Vice Chair. For the record, David Murray here with Chesa. Our industry employs over 4,500 solar workers, most of which are employed by our residential solar industry, which has installed over 65,000 solar arrays across Maryland over the last decade. We support the bill's statewide licensure elements and applaud Senator McCray for his leadership to support worker training, as well as streamlining doing business across Maryland. However, there is a provision on page 29, line 7, that would impact solar operations. This on-site requirement, which the fiscal note indicated may place a significant burden and increase operating costs for certain businesses. The solar industry finds this new requirement unnecessary, but it will also increase costs of solar and slow down the rate at which we can install arrays, specifically in the residential space. This would require a master electrician or journey person to be on site for the entirety of the solar installation, meaning he or she will need to be there when installers are hoisting panels onto a roof, mounting a racking system, clipping in panels, activities that the solar industry trains workers for, but do not necessarily require the specific experience of a master electrician or journey person. Currently, master electricians must closely review and sign off on every residential solar permit in Maryland. The installations are later inspected by county officials for quality and safety before they can be turned on. This is state practice in Maryland, and frankly, the majority of the country, leading to over 65,000 successful installs without this requirement in place. So why place this requirement now? In the work group that took place last fall, I asked fellow participants for specific instances that showed that the requirement was necessary for the rooftop solar industry, but was not provided any. After surveying our membership about this requirement, companies pointed to Massachusetts as the only other state they knew that had this requirement. But there's no evidence that installations in Massachusetts are any safer than they are in other parts of the country. Conversely, companies noted that the on-site requirement in Massachusetts added costs and created an artificial labor shortage in the industry, as companies struggled to retain journey persons who are willing to use their experience solely for solar installs, which, as I've noted, the majority of which does not require their training. Necessitating a master electrician or journey person to be on-site will add anywhere from $250 to over $1,000 per residential install.
Murray,
this is several months.
Please.
Yes. In conclusion, this adds costs and significant expense to residential installs, and I respectfully request the committee adopt our amendment. Thank you.
Thank you for your help with coaching us on your suggested amendment. That always makes our job a little easier. Senator McCray, I'm going to call this the Goldilocks Bill. You said it was too tight, and then it was too loose, and now maybe this one is the just right. So this is Goldilocks porridge here. There are two colleagues with questions, so if we can again try to keep questions and answers brief. Chair Pitsky asked me to try to speed things up. Senator Riley, followed by Senator Carozza. Senator Riley.
Thank you very much. Mr. Murray, are you with us?
That's correct. Hi, Senator Riley.
Good. So one of the folks talked about out-of-state electricians coming in to do solar work. Is that accurate?
Solar companies operate across the region. So most of our companies are based here in Maryland, but they typically simply get a permit from the required jurisdiction in order to perform services there.
But you missed my question. Do you understand the question?
Could you repeat that?
The electricians on site that wire the solar array into the meter, are they generally Maryland licensed?
That's correct. They have to be.
They have to be. Okay, thank you very much. Mr. Wilson, you with me?
I am.
Good to see you.
You too.
Yeah. Tell me, I'm having a solar array put on my roof in about 3 months. You know, we just started the permitting process, yada, yada, yada. What about the need to have a master licensed electrician for the putting on the racks and the panels? Is that the intent of the bill?
No. The bill is the actual, and at the end of the day, it actually helps out the solar industry, because where the requirement now would be to have a master pull it and be on site, a journey person, if they were a licensed journey person, could perform that hookup on site. Obviously, a journey person would be a lesser cost in terms of the installation, and they could perform that duty because they would be working under a master as a licensed journey person. So
got all that, but the question is the amount of time they have to spend on site during the installation. You're saying up the racks and the panels, it's not the intent of the bill to have that person there overseeing that, what do they call it, a DC wiring?
It's the inverter wiring.
Yeah, the inverter wiring down to the panel, but then your guy comes in, makes the final connection.
Right, because the lifting and the installation is all basically done under an MHIC license, which is a home improvement contractor's license. Right.
Yeah,
so,
very good.
but the push is to And there's been some instances where some of the converters have not been hooked up properly. They can be hooked up to where they're dangerous to our linemen and also, yeah.
I want this thing hooked up right on my house. I understand.
Yeah. Yep.
When you go through your journeyman and master license work, do you guys get trained on the DC side? Or is it really the live side?
No, it's because PV is fairly new. I mean, it's obviously exploded in the last 10 or 12 years.
PV stands for?
Photovoltaic, which is your solar.
Okay, we don't like initials here.
Yeah, so and actually the last 2 code cycles have addressed different parts of the installation where it wasn't as called out for in prior code cycles. And yes, the concentration now on training is being pushed on that because there is a lot more of that work going on, and there is an inherent danger with mixing AC/DC. But all in all, like I said, all the solar installers that I've worked with or around are competent, and it's just a matter of that final connection. I think is what concerns a lot of the electrical industry. So
yeah, and me too. Okay, Madam Chair, thank you.
Thank you, Senator Riley. We're growing questions here. So Senator Crosa, followed by Senator Washington.
Thank you, Madam Vice Chair. I'll be brief. I want to thank Senator McCray for bringing his work experience to this bill. My question is for Commissioner Wilson. You caught my attention. I represent a border district. So my question is, how does this bill benefit my rank and file electricians with Delaware to my north and Virginia to my south? And how, if I were to have a skeptical electrician who doesn't follow all these state bills and might have the impression that all this bill might do is to increase revenue, how do I respond and let those local electricians know why this bill is good for them?
Well, the bill, in terms of the portability and the ability to, especially the border counties, and it's one of the things that I've really pressed is the fact that, especially here on the shore, we see it. Delaware comes in, they can bring people across to the Maryland border that are unlicensed. I could take this entire committee out tomorrow under my guise, and you would all be electricians in the eyes of the state of Maryland. And that's the same with Delaware. They can bring 20 apprentices into the state of Maryland and work them as journeymen, where we can't do that the other way, and we can't do it here locally. So we're playing on an uneven playing field. And I'm just going to give you one example to break this brief. I just lost a $1 million job at a local YMCA in Kent County to a Delaware electrical contractor. And that's the kind of things that we need to get rid of. And in terms of the cost is not going to really, it's going to shift some. It's going to become more user cost because obviously permitting and things like that may change, but it's going to be a big benefit to the contractors, the master electricians, as well as giving the journey people something in their pocket that says, I am a journey person, and they can reciprocate with the states around us. So that's where I'm saying we can flip the script. Then we can go work in Delaware, bring some of Delaware's money to Maryland.
Okay, Senator Crosa, you good? Okay, Senator Washington. You're muted.
All right, thank you, Senator. Thank you, Senator, for bringing the bill. This bill is 31 pages. And so maybe not here, but I do hear, and sometimes in these bills, when they're, these omnibus bills, there are little things that are plopped in to just see if they'll fly. And so I do want at some point to really address, what Mr. Murray was talking about in terms of, and I think a little bit behind what Senator Crosa's folks who may be looking at this and wondering, who's it benefiting. So if you could, again, offline, if we could better understand the part, separate the parts of which are about licensing and really legitimizing, ensuring that particularly state-funded projects are safe and that our residents are safe, and those things that are more discretionary in terms of mandating certain levels that may or may not necessarily be required on every single project. So if you could help us sort of ascertain some of those, distinguish those things and separate those things out, that would be really helpful.
I appreciate you, Senator. Madam Chair, may I briefly comment?
Briefly, thank you.
Absolutely.
Yep.
got a comment.
First, I just want to thank Senator Carrozza, and I should have said this in the beginning because she actually attended some of the work group hearings, and I just was rushing past my testimony. The second piece to speak to the on-site provision, that's a norm. So
Right.
like we apprentices just randomly working out in spaces, and the electrician out there. So not having a master electrician isn't the norm, but a journeyman electrician is the norm. They're the first ones on site. You can have all the others, but the journeyman electrician is the first one on site, specifically for safety precautions. And thank you, Madam Chair, for your indulgence.
Absolutely. Senator Washington, you good?
Oh, yeah,
Thank you,
I'm good
Senator.
for now.
Okay, great. Seeing no other questions, that will complete the hearing on Senator McCrae's Senate Bill 762 until we see you back again. Thank you. The next bill, I want to acknowledge that Senator Edwards is with us. I think he's loving his visit to EHE. Senator Edwards, Senator Hayes is going to go first, then we're going to do you, and then we will go to Senator West. So Senator Hayes, I know that some of your witnesses are short-termers here. So you'll kick off. Senate Bill 859 is Department of Housing and Community Development Appraisal Gap from Historic Redlining Financial Assistance Program Establishment. And your witnesses, you'll start off with Bree Jones.
Jason Bennett, or Jason Bennett, the administrator, Allegheny County.
George, can you mute, please? Followed by our friend Wes Moore and then Sean Klosky. So Senator Hayes, you may begin.
Thank you, Madam Chair. I'm happy to go first, followed by Bree, who's our star witness. But I know Mr. Moore has a class to get to that he was supposed to be at like 20 minutes ago. Do you mind if he goes?
Mr. Senator, please, you can go first. That's fine. Please.
Oh, excellent. All right, cool. Thank you for your indulgence, and thank you. Good afternoon, Madam Chair and members of EHE. I've spent a lot of time this session in the wonderful committee, and thank you all for being so gracious to hear from me. Senate Bill 859. Today, I'm very blessed to be joined by Bree Jones, the founder of Parity, as well as Wes Moore, CEO of Robin Hood, and Sean Krosky from Rebuild Metro. Interesting idea how this bill came along. It really started with a conversation that Bree and I was having in my office as a result of some legislation that I brought to this committee before. And we've been talking about how, communities throughout the state can actually benefit from some investment from the state. Pretty much Senate Bill 859 will make financial assistance available to affordable housing developers working in low-income neighborhoods to close appraisal gaps that are a relic of Jim Crow era and the result of historic redlining. An appraisal gap, as defined, and especially in this legislation, is as the amount by which the total cost of construction or renovation exceeds the price that a home can be sold for. In simpler terms, due to appraisal processes, it costs more to build a home in certain neighborhoods than a developer would ever be able to sell a home for. This removes any financial incentive to invest in communities. These appraisal gaps prevent rehabilitation of abandoned and vacant buildings, discourage new developments due to the lack of economic incentive to pursue these projects. These gaps can range anywhere between $60,000 to $150,000. Decade of research has shown that houses in predominantly Black neighborhoods are constantly appraised at lower values than identical houses in majority white neighborhoods of equal socioeconomic status. Decades of neglect, disinvestment, declining neighborhoods have prevented the rehabilitation of these houses. I'm gonna cut my testimony short here today. Because I know you all and we're all under a tight time crunch, but essentially we've been working very closely with the Department of Housing Community Development. You've noticed they haven't submitted any testimony. Many of the amendments that we're submitting reflect that collaboration and eliminating some of the mandatory appropriations and other things. But essentially to narrow the scope of the bill, we're using the Maryland Department of Housing and Community Development already established and adopted sustainable communities, which you should have those communities in every of the 24 districts throughout the city. But essentially those communities identified by DHCD are communities where they see as a priority in leveraging community revitalization strategies from Western Maryland to the Eastern Shore. And then to narrow the scope even further, we would have the county exec or whoever is the head of those local governments identify the priorities even lower into that demographic area to make some of this change. Madam Chair, I'm going to end there for the sake of time today, but I urge a favorable report with amendments and look forward to hearing from the other folks to testify.
Thank you, Senator Hayes. Ms. Jones, if Westmore has a class, do you mind if we just switch the two of you guys? Okay. Westmore, welcome to Education, Health, and Environmental Affairs. It's great to see you here.
It's great to see you too. Thank you so much, Madam Vice Chair, and to all the members of the Education, Health, and Environmental Affairs Committee. Thank you for the opportunity to testify in support of a bill that I believe deeply is an important bill for consideration. And it really goes back to something that Senator Hayes was saying, is that for many families, owning a home is going to be their biggest source of wealth. For many, it is an asset that not only helps to provide housing, but it's the fulfillment of a promise, and not only a roof, but also financial comfort and flexibility. But we know that it has been and has rolled out in a way that has not been fair or equal to Marylanders. And we know that African Americans have been systematically denied the opportunity, as Senator Hayes was speaking to, that according to data by the Federal Reserve, amongst young families, about 46% of white families own their own home. That's compared to about 17% of Black families. When you look at Baltimore, the same disparities exist, where the Able Foundation just had a report that showed that Black home ownership between 2010 and 2017 dropped from 45% to 41%. This really stems from a larger history of broken and discriminatory and unfair housing policies that were very elegantly structured to disproportionately advantage one group over another. And its implications really show themselves very clearly today, where we really need to look no further than the Homestead Act, which gave thousands of acres of land to individual families, but it was not individually applied to African Americans, or redlining, the 20th century discriminatory practice that made home loans unavailable to Black neighborhoods. When Black families do purchase a home, they often do purchase a lower valued homes located in neighborhoods that experience less price appreciation. And if you look in Baltimore, for example, in 2015, the Baltimore Neighborhood Indicators Alliance estimated that about 31,000 buildings or lots were vacant. So understanding the fact that these type of disparities are not only unjustified, but not accidental, they're also not irreversible. And it's the reason why I think this bill is so important, because it does help to focus on things like help to rejuvenate underdeveloped neighborhoods, increase home ownership and build wealth among low and middle income families, support mission-driven, affordable housing developers, and create jobs and economic opportunities. And today we actually have an opportunity to play our part in eliminating those type of racial disparities that exist. I think about, me being here.
I need you to wrap up. Sorry.
And so I just close simply saying I'm proud to support SB 859, and I hope that you'll vote in the affirmative.
Thank you so much. Have a good class.
Thank you.
Ms. Jones, welcome to EHE with Parity Homes. You get up to 5 minutes, but you get bonus points if you're a little quicker.
All right, I'll do my best. Thank you. Thank you to the committee for giving me the opportunity to testify, and thank you to Senator Hayes for sponsoring this bill. I'm here in support of the appraisal gap from historic redlining financial assistance program. I'm going to read a deed restriction for a home sold in College Park in PG County just 80 years ago when my grandmother was 10. Subject to the covenant that the above described property or any part thereof shall never be sold or conveyed to any Negro or any person of the Negro race or having Negro blood. Redlining, in combination with blockbusting, contract lending, and urban renewal, in which Black houses were demolished to build highways, were a decades-long process still ongoing that systematically robbed and continues to rob Black Marylanders of their wealth. My name is Bree Jones, and I'm the founder of Parity Homes, which is an equitable, community-led development company that removes systemic barriers for people to equitably rebuild historically Black neighborhoods together. Parity employs an innovative but simple model to revitalizing hyper-distressed neighborhoods by creating pathways for existing and new residents to collectively buy homes together on a block-by-block basis. And yet in the 21223 and 21217 where I work, our neighborhood is one of the most economically distressed areas in Baltimore because of historic redlining. There persists an issue that prevents redevelopment of housing in the Black Butterfly called the appraisal gap. The appraisal gap is a unique phenomenon in which historically redlined communities see that the cost of development to renovate a deeply distressed building exceeds the appraised after repair value of the building and exceeds the price at which that home can be made affordable to existing residents. And so this results in either two outcomes. In one case, the community continues to face deterioration indefinitely and no development happens at all. And in another scenario, development is done at very poor quality, perpetuating the danger of unstable and unhealthy housing in low to moderate income communities. But with this bill, we can provide a way forward. We can provide a more equitable outcome. This bill would be able to create more homeowners, create more wealth, and create inclusivity statewide. This bill provides a way forward to begin to heal historic harms and revive healthy communities. This bill would directly impact the racial wealth disparity in Maryland state. And so for these reasons, I request a favorable report of SB 859, and I genuinely hope that you consider this bill as an innovative way to create an inclusive Maryland. Thank you.
Very much, Ms. Jones, for your testimony and your leadership on this issue. Next is Sean Klosky. Mr. Klosky, Rebuild Metro.
I'm the president of Rebuild Metro, and we're a community group that's invested over $100 million into East Baltimore. And in the result of that is we've been able to eliminate over 700 blighted and abandoned properties and created price appreciation of over 550% without displacing anybody who is in the neighborhood. The appraisal gap is a real issue for us. We wrestle with every day. I think that the other two speakers, I wholeheartedly agree with their analysis. And what we're trying to do is say that without public support, you can't draw enough private sector money in to resolve the issue. What I think is also important is to look that this isn't just a Baltimore issue. This is an issue that has statewide implications. If you look at the appraisal gap and you look at the cost to substantially rehab a house, and you look at Maryland's housing prices, there are 190,000 houses in the state of Maryland whose price is below the substantial renovation cost. And that includes 145,000 houses outside of the city of Baltimore. Part of this is based on concentrations of older homes in the state, and it's a state that has lots of houses that were built prior to 1950, about 500,000 of them, and those exist throughout Baltimore City, Hartford County, Baltimore County, Montgomery, and Prince George's counties. Collectively, they have about 350,000 of those homes. In addition, it's the tenure of families living in houses for decades. And what happens is you see families get used to houses. There's some deferred maintenance. They live on a fixed income, so they may not update or fix things that need to happen. And what happens when you look at the houses where folks have lived for more than 40 years in houses in Maryland, they represent about 320,000 houses. And they're well represented.
I need you to wrap up, please.
Okay, thank you. So the two facts are, this is really important, and if you don't invest in these houses, the abandonment only increases.
Thank you, Mr. Klosky. Senator Washington, you have a quick question?
I do, and thank you, Mr. Klosky and Ms. Jones, for while a lot of your examples were in Baltimore City, saying this is a statewide issue, in older communities across the state and the country. I guess just real quickly, just because again, how would this work exactly? So is it a grant? Is it you're allowing sometimes what we do for Under Armour or for other where we allow, is it sort of a TIF situation? Exactly how is this working? That
So,
would be.
thank you, Senator Washington. Two things. One, obviously, it's easier for me to get people to testify from Baltimore because I know them, right? But we have had
Yeah.
with a bunch of people from all around the state, including Habitat for Humanity's Chop Tank, does a lot of work on the Eastern Shore, and many of them have submitted work on this. We left it broad on purpose, and that's really what the advice of DACD. The executive branch does not take well to us mandating mandatory appropriations or how they spend the money. I will tell you there's federal legislation, it's federal bipartisan legislation that has the potential to supplement this, that's being sponsored by Senator Cardin, and it's working its way through. And that actual, federal legislation is a tax credit. But given the advice of the experts and those folks that are, working in the agencies, we didn't want to direct the executive branch. Really what we wanted to do with EHE was kind of create the policy framework and to work with the amendment so they could apply the most appropriate financial assistance that they see that they should apply to it.
Okay, great. All right, thank you. Thank you, Madam Chair.
Thank you, Senator Washington. Senator Croza.
Thank you, Madam Vice Chair. And I think just to follow up on the Senator Washington's question to the sponsor, you sometimes have a goal in mind, but then the policy approach with the mandated spending and the $4 million per year annual appropriation. Did you have any conversations, Senator Hayes, on other either incentives or other approaches to reach the same goal? Again, just as a former budget committee member on the House side, just sensitive to that and trying to see if there were other incentives or voluntary programs that maybe you would look to achieve the same goal.
So one of the things, Senator Carosa, I don't work in this area. I would love for Rebuild or one of them to jump in, but in conversations with DHCD, I think what's really attractive to some of our conversations, that they've heard from community development corporations and others around the state that have been trying to meet these goals, but haven't, a lot of the programs that they have, whether it's Community Legacy, whether it's Bernie, all of the other tools that they have don't really get to the specifics of this issue and addressing the appraisal gap as described in this piece of legislation. And so this appeared to them to be a very attractive proposal to address something that they have been kind of contemplating for some time. And I'm very lucky to have the benefit of keep on, using the expertise of those people who are been out in the field, a part of these community development organizations and stuff to try to make this happen. I am not that smart to come up with this piece of legislation. It's really the intellectual input of those folks who are out in the field that help bring this together.
Okay, so with that, I see no other questions and there was no opposition. We have informational testimony from the Department of Budget and Management, but no opposition. So Senator Hayes, thank you so much for being here and working on this bill. That completes the hearing on Senate Bill 859. The next, Senator Edwards, finally, we're so glad you're here. Thank you so much for your patience, but we are glad you're here with Senate Bill 804, Garrett County Memorial Hospital Board Membership and Meetings. That sounds like a very controversial bill. So I'm going to take careful notes. Welcome to you.
It is, and I'm always take my time. So I will be very, very quick on this. We'll ask for your support for Senate Bill 804. Thank you, Madam Vice Chair, who said what the title was. What it does is changes the makeup of the board from 15 to 9. 5 of those board members come from specifically listed organizations. The other 4 are at large. And to get elected at large, you have to have at least 3 affirmative votes. It changes, they have to meet 6 times a year. And the terms are staggered, 2-year terms for at large, and they're staggered as they go from year to year. With a very, very, very tough bill to vote on, I know that. And I think, I don't know if Kevin Knoll's still in there or not, the county administrator. If he is, he probably doing it's going to say me too, but I hope
I see him here.
Bill.
Yes, sir, I'm here.
Okay, do you want to say me too, or you want to add an explanation?
Nope, I will say me too. The only thing I'll say is that the Board of Commissioners, Garrett Hospital, and the town of Oakland all support the bill. So thank you.
Okay, Senator Edwards, you know that you'll have to wrangle your delegation to make sure we get a unanimous delegation letter, okay?
Yeah, that'd be probably a long discussion on that. So it might take a little time, but we'll
I'm
take
thinking
care of
that. So if there's an amendment or something, you just let us know once
Thank
you
you.
have the delegation meeting. That completes
Thank
the hearing on Senate Bill 804. So sorry we kept you waiting for so long.
Thank you.
All right.
Thank you so much. Senator West, good to have you back here in EHE. You have Senate Bill 808, Health Occupations. We haven't had one of those bills for a while. Licensed dentists, administrations of vaccines. And I should tell you that my Legislative and Communications Director just messaged me that she got her first vaccine and got it from a dentist. So whatever that's worth. All right. Following your testimony, we have Arthur G., who I saw was in the room, followed by Leslie Grant, and we will have some others as well. Why don't you kick us off? Welcome, Senator West.
Thank you very much, Madam Vice Chair. Sometimes I wish the Baltimore County Senate delegation achieved unanimity as easily as the Garrett County delegation. So I'm pleased to introduce Senate Bill 808. This legislation seeks to authorize a licensed dentist to administer certain vaccines to certain patients under certain circumstances. There are currently 5,000 dentists in Maryland. Many dentists see their patients more often than they're seen by their personal physicians. Patients generally visit their dentists once or twice a year. Since I was a child, I've always gone twice a year. Dentists already provide more injections than any other healthcare provider in the state. This legislation would establish a well-regulated system in which dentists could be properly trained and equipped with the tools to effectively vaccinate patients. I notice in your package, you're going to see lots of letters from members of the state's anti-vaccination community. I think if they listen carefully to my testimony, they will find that this bill contains lots of protective provisions, which should answer many of their concerns. Under this bill, no dentist would be required to offer vaccinations to patients. A dentist's decision to offer vaccinations at all and to offer particular vaccinations would be a voluntary one. Dentists that choose to offer vaccinations will be required to take a dental board approved course that includes instruction in the guidelines and recommendations of the CDC regarding vaccines. Then during every other licensing renewal cycle, a dentist will be required to complete a board approved continuing education class of at least 2 hours that deals with vaccination issues. Senate Bill 808 provides that a licensed dentist can administer vaccines to 3 groups. 1, a flu vaccine to a patient who's at least 9 years old. 2, a vaccine that's listed in the CDC's recommended immunization schedule to a person between 11 and 18 years old who has a prescription from an authorized provider and operating under a written protocol that is vaccine specific and meets criteria contained in Department of Health regulations. And 3, can administer a vaccine to an adult that is either listed in the CDC's recommended immunization schedule or that is recommended in the CDC's health information for international travel. In each of these cases, before administering a vaccine, the bill requires the dentist to obtain from the patient, or in the case of a child, the child's parent or guardian, a signed medical history and a signed consent form that clearly outlines the benefits and risks of the particular vaccine. Senate Bill 808 also contains elaborate reporting requirements. A dentist administering a vaccine is required to report all vaccines administered to the state's Immunet program. Also is required to try to inform both the patient's authorized prescriber, in the case of a prescribed vaccine, and the patient's primary care provider of the administration of the vaccine. In addition, the bill requires the dentist to enter relevant information about the vaccine in the patient's chart and to provide the patient with a vaccination card that contains all relevant information about the vaccine, including any post-vaccination instructions, a list of the possible side effects of the vaccine, instructions for addressing possible side effects, the dentist's after-hours personal contact information in the event of an emergency reaction, and the name of the urgent care center closest to the site where the vaccination was administered. Senate Bill 808 is being supported by the Maryland Department of Health, the Maryland Board of Dentistry, the State Board of Nursing, the Maryland Dental Association, and the University of Maryland School of Dentistry. Now, the Attorney General has issued a letter with a few concerns in it, and the letter is pretty simple. And if the committee chooses to introduce an amendment to incorporate the two concerns that are in the letter, which are very easily handled, I will regard that as a friendly amendment. So in summation, Senate Bill 808 will help to improve vaccine distribution and allow for greater access to these vaccines. In passing this legislation, Maryland would join other states such as Oregon, Illinois, Minnesota, and Georgia, which have already passed similar bills. COVID-19 has shown how important it is to have proper vaccine distribution. And by allowing our dentists to assist with this process, we will provide greater access to healthcare for all Marylanders. For all of these reasons, I hope you'll give Senate Bill 808 a favorable report. And I have two witnesses who are eminently qualified to supplement my testimony and answer questions.
Thank you, Senator West. We appreciate your bringing this bill. There are a lot of proponents and opponents, so we will kick off with Arthur G., MSBDE. And who's going to start off by translating that for us, if you could? Dr. G.
So that's Maryland State Board of Dental Examiners. So thank you, Madam Vice Chairperson and members of the committee. I appreciate the opportunity to speak. I'm Arthur G., immediate past president of the Dental Board. The Dental Board, of course, supports Bill 808. I wish to point out that this bill is not a debate on the merits of vaccines. This bill supports well-qualified, well-trained healthcare providers, that is dentists, to aid in controlling contagious communicable diseases that affect all Marylanders. The Dental Board believes that dentists already have the ability of giving vaccines, first under the governor's current order, and secondly, the fact that it complies with Health Occupation Statute 4-101 under the definition of dentistry, where it's taught as part of a curriculum at the University of Maryland Dental School. What the bill does provide is the statutory power to unquestionably develop regulatory guidelines, establish and administrate educational requirements, record keeping, and uniform training. In this bill, that the order does not.
You're breaking up.
To formally discuss.
I don't know if getting closer to your microphone would help at all, but we're hearing parts of your testimony, I think. Go ahead, try again.
So this allows, okay, this is the inarguable position faced with the medical legal insurance liabilities. This is also an access to care bill. According to the Agency of Health Research and Quality, more than 31 million people in the United States sought care from a dentist and not a physician. And according to the American Dental Association, approximately 9% of Americans see dentists and not physicians annually. I direct you also to the 2019 Maryland Oral Health Legislative Report, where various DOH oral health programs and donated dental programs saw over 34,000 Marylanders, most of all who were queried, admitted not having seen a physician in the last 5 years. So, according to the American Association of Dental Boards, the 24 states already give ability to give vaccines. The states are already listed, you know. This is strongly supported by the CDC Advisory Committee on Immunization Practices, the U.S. Health. And there are over 5,000 Marylanders who are geographically located in every nook and cranny of the state. If you'll note that the bill is very specific, there are concerns about the fact of giving vaccines to children and supplementing the welfare of children. Note the age is 11 years of age. And by normal pediatric schedules, most pediatric welfare care is given by the age of 3 to 6. So there's no dentist that would legally be able to substitute a well visit. The participants must require immunization, and likewise, they go through the process as described by Senator West. The vaccines primarily interested by dentists would be, of course, the COVID. In addition, it would be the HPV, which is the human papillomavirus, which the CDC says 70% is accredited for oropharyngeal cancers. Obviously, tetanus, there's trauma, and there's actually bites. And obviously, there's hepatitis B, which we're talking about bloodborne pathogens. That concludes my report, Senator. I hope I did it quickly enough for you.
Thank you, Mr. G or Dr. G. I didn't, if you have, it says here that you only have oral testimony. If you have a copy of your remarks, since we couldn't hear all of them and you'd like to submit them, then we can have the benefit of that and review them with counsel. So if you can do that, that would be helpful. And next we're going to hear from Leslie Grant, then Charles Doring, then Thomas Beckett. Leslie Grant, Maryland State Board of Dental Examiners.
Good afternoon. Thank you, Madam Vice Chair and committee members, for this opportunity to speak today. My name is Leslie.
Uh-oh. Ms. Grant, you are frozen. Senator
Grant, I'm a general dentist, and I've also been here for more than a decade, and I've completed their vaccine training recently, earlier this year. I appreciate Senator West sponsoring Senate Bill 808. And this bill amends the Dental Practice Act to include vaccine administration and provides requirements for training, informed consent, documentation, and reporting. SB 808 will expand the opportunity to contribute to disease prevention in our state, including our most vulnerable populations. Dental practitioners offer a great safety net for providing vaccinations. We are amongst the most trusted of healthcare providers. Prevention is a hallmark of our profession. We are adept at educating patients and are well positioned to address vaccine hesitancy. Dentists are experts in injection administration and precision. We provide more injections than any other healthcare providers, and we know how to ameliorate concerns regarding fear of needles. Dentists incorporate proper dosing and dispensing protocols, as well as sharp safety in our everyday practice. General dentists typically see more patients more frequently than physicians. We treat the entire family and often multiple generations within one family. Dentists offer care in environments where safety is paramount, and treatment is delivered by providers who have long-term familiarity with implementation of infection control protocols, aerosol safety, and the proper sequence for donning and removing of personal protective equipment. We provide care across a wide range of settings, including private offices, training institutions, correctional facilities, school-based health centers, nursing homes, and community health centers. This bill is good for public health. It strengthens collaboration within the health team.
Ms. Grant, if you could wrap up, please. Your time has expired.
Yes, ma'am. It provides an enhanced level of care, and several states have already expanded their scope of practice to include vaccine administration by dentists. I want to emphasize that this is now a part of the curriculum at the University of Maryland School of Dentistry. Thank you
so much. It's so tough. I know you all have a lot you want to share with us, so we appreciate your being here.
Especially since the audio, you couldn't hear the audio very well in our primary speaker.
But it got better towards the end, so we're glad you're here. Dr. Doring, welcome back to EHE.
Welcome, glad to be back. And I am in my office. I do have some staff here, so I apologize for wearing a mask. I don't apologize, but I'm glad to do it. Charles Doring, a general dentist, Rockville, Maryland, here representing the Maryland State Dental Association in support of Senate Bill 808. I want to thank Senator West for his great introduction. I'll keep this short because I want to thank the Maryland Reserve Medical Corps. I joined up and I'm awaiting to be deployed to give the COVID-19 vaccine. One of my colleagues here, Dr. Lenny Byrne, was over today at Prince George's County Health Department providing vaccines. And as Dr. Grant said, it's now in our curriculum at the University of Maryland School of Dentistry, where I'm on the dean's faculty. I do think the bill, as Senator West mentioned, has some safeguards that hopefully would address the concerns of the pediatric community. I do think there are some oral conditions where this would benefit, primarily the HPV vaccine. We talk to our patients, especially adolescents and their parents, and recommend these vaccinations. I know I've gotten many questions myself, so 100% of my staff has been vaccinated for COVID-19, and we allay a lot of the fears. And just lastly, I know some of you may have had some dental work and may have been a little bit nervous, but we give great mandibular blocks. So giving a vaccine in this fashion, like the COVID-19, would be pretty routine, even for the most nervous patient. So with that, I would ask the committee for a favorable report on Senate Bill 808. Thank you.
Thank you, Dr. Doring. Thomas Beckett, you're in next. Welcome.
Good afternoon, Chair Penske and Madam Chair Kagan, members of EHA. I'm Dr. Tom Beckett. I'm a past president of the Maryland State Dental Association and vice chair of the Legislative Committee. Senator West did a great job telling you all about the bill. I'm going to be very brief. I'm speaking in favor of Senate Bill 808 to allow my dental colleagues to be part of the broader solution. My opinion that dentists, by the nature of our practice, give more injections than most other healthcare providers, part and parcel of our daily routine. A quick calculation I did this morning that over my 40+ year, I've given tens of thousands of injections. I know the fears, the phobias, etc. It's easy. We are trained to do this. Not a problem. As a quick aside, one of my colleagues in DC who got his COVID-19 vaccine in the hospital setting, the doctor vaccinating him was a retired psychiatrist who informed him that he hadn't given an injection in over 45 years. Who would you rather put that damn shot in your arm? I ask for a favorable report in Senate Bill 808. Thank you very much.
Thank you for your brevity, Dr. Beckett. We appreciate it. So those are the proponents. Senator Washington, I see that your hand is up. Would you like to ask your question now, or would you like to wait until after the opponents? And you are muted.
It's really just allowing me to recognize my constituent, Dr. Grant, Leslie Grant, just thanking you so much for being here. Thank you. Thank you for allowing us to better understand the project. That's just a point of personal privilege.
Absolutely. Dr. Grant, you are very, very well represented here in Annapolis by Senator Washington. I'm sure you already know that. We're going to pivot to the opponents. We will kick off with Megan Montgomery, followed by Pam Casemeyer and Emily Tarsell. So Megan Montgomery.
Good afternoon, Madam Vice Chair and members of the committee. I will be very brief. I know time is of the essence. I'm not sure who Senator West was referring to with his anti-vaccine committee comments, but that certainly does not apply to me. I am a responsible parent who gets my child all of the health care that I need, and that includes a dental visit where I have merely minutes with the dentist after the technician cleans my child's teeth so that I can talk about braces or extractions or spacers, and taking up any of those precious minutes with a discussion about vaccines that are better held in a pediatrician's office is not really something that I'm looking for in a dentist. I don't take my child to the pediatrician and talk about braces because it's not the appropriate match for healthcare. Also, I just want to say very quickly that I cannot imagine a scenario in which my pediatrician would give me a prescription for a vaccine and say, here, take this to your dentist. That has never been my experience, and I can't imagine it's anybody else's. Thank you for your time.
Thank you very much, Ms. Montgomery. Good luck with your little ones, ones. Pam Casemeyer, MD-AAP MACHC.
Yes, hi. Pam Casemeyer here on behalf of the Mid-Atlantic Association of Community Health Centers and the Maryland chapter of American Academy of Pediatrics. I would, even though we are here in opposition, I would like to make notice of this bill as opposed to the pharmacist vaccine bill you heard earlier today. I will say on behalf of my clients, this bill is structured much better. It doesn't get rid of the prescriptions from the pediatricians from age 11 to 18. But I think what we're concerned about, and maybe there is an appropriate role of integrating dentists into this space on a longer term basis. Again, we're very concerned about making judgments about permanent frameworks because of COVID actions, because there's long-term health structure and there's COVID response. But this issue's never even come up before. So thinking through, the response was really, well, maybe there's a way this fits. We're not sure. they basically took the statute that's in for the pharmacist now and moved it into the dentist. That may be the appropriate structure. It may need some adjusting. There may be different types of communication or more limited types of vaccines or broader. So we really feel like it's not a discussion we aren't willing to have. But I think it's sort of out of nowhere, and expanding it with unintended consequences like fragmented healthcare or communications or inappropriate structure just doesn't seem like the right way to go in year one. So while we think that they built a much better structured bill, we think the dialogue sort of just started, and it's kind of perplexing to know exactly how to respond when it sort of came out of nowhere.
Thank you. Thanks, Ms. Casemeyer. Emily Tarsell?
Yes, thank you. Good afternoon, Vice Chair and Senators. I'm Emily Tarsell, and I'm here on behalf of Health Choice Maryland to oppose Senate Bill 808. Dentists, among others, are seizing the pandemic moment to expand revenue sources by seeking authorization to broadly vaccinate. The American Dental Association has sponsored an essay contest titled "Why Your Dentist Wants You to Get the HPV Vaccine." So one of the agendas is clearly to allow dentists to give the lucrative HPV vaccine, Gardasil, apparently without parental consent because it only says representative. It doesn't specify parents in the bill. And the FDA recently approved Gardasil to allegedly prevent oral throat cancer, even though there's no evidence it would do so. Now, HPV-related cancers are extremely low in the US, especially in the young, and are associated with other risk factors like smoking. But if this bill passes, dentists will hype the threat of oral throat cancers, especially to youth, like they did for cervical cancer, and try to scare them into vaccinating. The truth is, the real risk is the vaccine itself. Adverse outcomes from HPV vaccinations are 3 times greater than all other vaccines combined, with more than 10,000 seriously injured youth and 525 deaths, including the confirmed Gardasil-induced death of my 21-year-old daughter 12 years ago. A recent peer-reviewed paper was titled "The Expanding Cocktail of Harmful Ingredients in the HPV Vaccine," documents the presence in Gardasil of a highly toxic chemical used in biological warfare with known side effects congruent with those reported from vaccination. And governments in other countries have withdrawn recommendation for the vaccine, and there are lawsuits pending worldwide for failure to inform. So we have no objection to dentists making an income, but not by exposing our children to increased risk. And so we ask an unfavorable report for SB 808. Thank you very much.
Thank you for your testimony, Ms. Tarsell. When you just said "we," can you just clarify, please, who you're representing or who you're affiliated with?
Yes, Health Choice Maryland.
And okay, great. Thank you so much. Okay, I see no questions for any of our witnesses, so we are grateful for your patience and your testimony. And that completes the hearing on Senate Bill 808. Thank you, Senator West, and passing it back to the chairman.
Thank you, Madam Vice Chair. We're going to go to Senator Jackson, 873, Department of Information Technology, State and Local Government Employees and Contractors. I have Senator Fry Hester as a witness afterwards, and then I have Justin Fiore in opposition. So Senator Jackson, welcome to EHE.
Thank you very much, Mr. Chairman and members of the committee. For the record, Senator Jackson on behalf of Senate Bill 873. Senate Bill 873 is a piece of legislation that implements one of the chief recommendations from the Joint Committee on Cybersecurity, Information Technology, and Biotechnology in creating a statewide cybersecurity training apparatus. In an effort to better protect private information entrusted to both state and local government, the bill would require the Department of Information Technology, in coordination with the Maryland Cybersecurity Council, to develop criterion for the certification of varied cybersecurity training programs used annually by required state and local government employees who have access to sensitive information. The certification criteria would focus on forming information security habits to better protect information resources, personal information and records, while also teaching best practices for detecting, assessing, and addressing information security threats. The legislation would also require corresponding state and local government employees, as well as certified contractors, to complete said training programs, and require the government units to report the completion of the employee training to the Department of Information Technology. To ensure compliance for these certification programs, the bill includes audit requirements at both the state and local level. The bill would additionally mandate the Department of Information Technology to certify at least 20 different cybersecurity training programs and to maintain a list of all certified programs for use by state and local governments. As a Homeland Security professional and the former House Chair of the Joint Committee on Cybersecurity, Information Technology, and Biotechnology, I have become acutely aware of the necessity of improving cybersecurity throughout state and local government. This piece of legislation is a significant step forward in achieving that aim and ensuring safety of vital personal and public information. About a week or so before session began, I actually completed my Prince George's County version of this security awareness training, Mr. Chair and members of the committee. Attached, you will find there's an amendment which allows the contractors that are engaged with our state and local governments who have access to certain information. They also have to be trained, but the amendment would allow them to submit a training program of their own, but it has to qualify per the Department of Information Technology. So with that, Mr. Chairman and members, I'd ask you and the committee for a favorable report with amendment for the legislation, and with your consent, I'd like to bring my former co-chair of the Joint Committee of Cybersecurity, Information Technology, and Biotechnology to offer any additional testimony and to assist in answering any questions. She's former because now I'm a senator and I'm no longer the House Chair. So thank you very much.
Thank you, Senator. And Senator Frey-Hester, if you'd like to add anything to his testimony.
Thank you, Mr. Chair. I was very happy to see the good senator join us over here in the Senate, but miss having him as my co-chair. So hopefully we'll keep him on the committee. I just wanted to reiterate, a couple points that Senator Jackson noted. One is that, we did vote on this piece of legislation, and I think it passed unanimously out of the Joint Committee. But it's also being considered as part of this package before the working group on cyber in this committee here in EHE. And we talked, when we convened on Monday night, we had MACO come, and they were very clear about not wanting to have additional financial mandates on local units of government. And then we had a really productive conversation about how it's in everybody's best interest that we make sure that everybody who's on the Maryland network is following some minimum guidelines for cybersecurity, that there's resources and standards that are available for people to follow, and that training is a critical piece of this. And so it's an ongoing conversation. But I would just, as Senator Jackson said, support this legislation and urge a favorable report. Wow.
Thank you, Senator Hester. We have one person in opposition, but any questions for either Senator Jackson or our own Senator Frey-Hester? Seeing none, let's go to Justin Fiore from MML.
All right, good evening, Mr. Chair, Madam Vice Chair, committee members. For the record, my name is Justin Fiore, and I'm here on behalf of the Maryland Municipal League in opposition to Senate Bill 873. We've witnessed large-scale ransom attacks on local government systems across the country and here in Maryland. For those reasons, I totally understand the intent of the bill, and local governments could certainly use some help. We are, however, concerned with how broad this legislation is and what it might cost local governments. In our reading, it requires too many people in governments and contractors to complete programs that we can't fully vet the costs of yet. And risk is just not uniform across all our employees either. Furthermore, here's what my members are telling us. While training is important, people are going to make mistakes. The bad guys in this field are very good at their job. What's more important is having the cyber infrastructure in place to ensure that sensitive data and critical systems are protected through what I'll refer to non-technically as a safety net. So that if a town clerk's email gets hacked, those hackers can't compromise sewer and water services, steal residential data, or hold other operations hostage. An example of an alternative approach that we would enthusiastically support would be legislation passed by the House last year that instructed DO IT to develop guidance on a consistent cybersecurity strategy for counties, municipal corporations, and school systems. We have found time and time again that proper planning and guidance works better for municipalities than one-size-fits-all mandates. With that, we respectfully request an unfavorable report on Senate Bill 873.
Thank you, Mr. Fiore. Senator Kagan.
Thank you, Mr. Chairman. Mr. Fiore, always good to see you. Thank you. I just want to make sure that you're aware that Senator Hester is chairing a work group on cybersecurity and looking at a number of different bills and looking to answer questions, and Senator Jackson's input always welcome and stuff. But I just wonder, do you have amendments? You referenced another bill. If you have amendments or have thoughts that you can pass along to Senator Jackson, Senator Hester, or our work group, I suspect we'd love to hear about them.
Thank you for the isn't that so?
Yes, but I am asking, do you have amendments actually? So I am actually asking questions.
I don't have amendments now, but as always, the Maryland Municipal League, even on bills that we might oppose in the base broad aspect of the bill, we're happy to be at the table. And so Senator Hester, Senator Jackson, I'm more than happy to work with you on this bill or any other cybersecurity bill that will have municipal impact.
Great. Thank you, Mr. Fiore. Thank you, Mr. Chairman.
Mr. Fiore, so you have been aware and participating in the work group or not?
It's news to me, but I may have a colleague that's involved, so I'll touch base with our folks, but I'm not aware of this particular work group.
Okay.
Thank you anyway.
Further questions, seeing none.
No, well, I didn't really give you good.
Thank you, Senator Jackson. That concludes the hearing on that bill. Two left. We're going to get a Senator 836, Board of Dental Examiners Disciplinary Action. We'll start with Senator Beidel presenting her bill, and then we will go to ask her any questions you may have of her in the bill. Then we'll move to the opponents, Margaret Kern and Arthur G. Welcome, Senator Beidel.
Thank you, Chairman Pinsky and Vice Chair Kagan and the members of the committee. Thank you very much for hearing Senate Bill 836. For the record, I'm Pamela Beidel representing District 32. So as you know, many of our bills are drafted because of an issue that we hear from our constituents. This certainly is true of Senate Bill 836. Anne Arundel County had a local dentist that since 2009 received multiple complaints about his inadequate dental work. Finally, in 2020, he surrendered his dental license. The many patients he injured had little recourse, either had to depend on this, oh, I'm sorry, just lost my document. Really lost my document. So much for technology, huh? Okay. Give me a second, please. Here we go. I'm sorry. I've got an issue. I'm losing my document here. So let's see if I can just wing this.
We're sure you can. Just
since, give me 1 second.
Okay.
We all love technology, except when it doesn't work, right?
Yeah, it was fine. I was testing it all before we started. So anyway, the many patients he injured had little recourse. They either had to depend on the State Board of Dental Examiners to protect them or file a civil suit, as the dentist did not carry dental malpractice, or at least he didn't have what we call a tail at the end of his time as a dentist. Fortunately for some patients, several local dentists stepped up and did pro bono work for patients that had already paid for dental work that was either never completed or were so poorly done that the prosthesis or implants had to be removed and redone. These are the lucky ones. Most of the patients owe loans for large amounts, often $15,000 to $40,000 or more, for work that was not completed or dental work that needed to be redone. Now the patients are paying again for this work to be completed. The State Board of Dental Examiners is prohibited from hearing cases about fees that are paid, and in many cases, I'm describing patients that paid up front for dental work that was never completed. The State Board of Dental Examiners confirmed with me in writing that this one dentist had official complaints in September 2009, 2012, 2013, 2016, 2 cases in 2017, 2 cases in 2019 regarding this one local dentist. As there's a Facebook page with 295 members that they were either injured by this dentist or were employed by this dentist and left because of the lack of quality of his work. In December, Senator Alfred, my co-sponsor, and I spoke with Mr. McLaughlin, the Executive Director of the State Board of Dental Examiners. He shared with me how difficult it is to complete the process of disciplining a dentist. The process requires a patient to file a formal accusation against a licensed dental professional, complete with a signature alleging a violation of professional standards. Another difficulty is that other dentists or healthcare providers who see the substandard dental work cannot provide complaints. So Senate Bill 836 is modeled after the process to use the Board of Physicians discipline process for physicians because it doesn't take 11 years with the Board of Physicians. One of the complaints I hear from the State Board of Dental Examiners is that they do not want the disciplined dentists listed publicly on the State Board of Dental Examiners. I would like to point out that physicians are disciplined are listed on the Maryland Board of Physicians website. Physical therapists, occupational therapists, and other providers are listed on the Maryland Health Department website, and nurses are listed on the Board of Nurses. Attorneys that are disciplined are listed publicly on the Maryland Courts website. Why shouldn't the Board of Dental Examiners notify the public when a dentist is disciplined? Why are the dentists treated differently? The Maryland Judiciary shows that this particular dentist has 186 entries in his case search, and 35 of them he's the defendant, with cases going back to 1996. The mission of the Board of Dental Examiners is to protect the citizens of Maryland and to promote quality health care in the field of dentistry. There must be a better way to provide for discipline and oversight of dentists in the state of Maryland. It's my understanding that the State Board of Dental Examiners will be opposing the bill, or they may ask for an interim study. I accept that this bill is now in the jurisdiction of this committee, but I ask, can we wait another year? And how many more patients must be injured by dentists that should not be practicing in Maryland? I want to add that I heard today from the Office of the Attorney General and the attorney that's been handling these cases that went through bank loans. So you can get a bank loan through a dental office. She's been able to get some of the money returned, $156,000 so far, but she's got, I think it's like 56 cases she's working on. And the problem was when the dentist abandoned his office, when he surrendered his license and abandoned his office, he didn't have access to his records. So he couldn't provide the records to the Office of the Attorney General so that they could go back and help these folks get their money back from the banks. And so they had to subpoena him and order him to recover his records so that he could then turn them over to the Office of Attorney General. This has been a nightmare, but as I've learned more, and I learn more every single day, I've talked to, I think, the Office of Health Arbitration. They never hear back from the dental board. I've heard from an attorney today that files about 70 cases a year. He's had 23 cases against this dentist, Dr. Neil Woods of Severna Park. So 23 cases against just this dentist. This has just been a nightmare for folks and a lot of pain, a lot of money. And I know that the dental board's going to object to this, as will the health department, but I just hope that this committee can find a way to do a better job of disciplining these dentists that are doing such poor dental work. And I turn the bill over to your jurisdiction and I ask for help in a favorable report. Thank you.
Thank you, Senator. Greatly appreciated. Questions for Senator Beidel before we move on to the opponents? Questions for the bill sponsor? Seeing none, we will go to the opponents then.
Thank you.
Thank you, Senator Beidel. You're welcome to stay or leave depending on what your other responsibilities are.
Thank you, Mr. Chairman. I plan to stay.
Okay. Let's hear from Margaret Kern, followed by Arthur G.
Chairman, members of the committee, thank you for this opportunity. I am Margaret Kern, Dental Board member. Senate Bill 836 has a great many issues. The dental board would be required to notify discipline committees. Dental practices do not have discipline committees. In addition, the dental board has no authority over facilities, only individual licensees. Number two, reporting of allegations should only occur after charges are issued. The bill requires the board to report complaints, which are allegations and unsubstantiated until they have been investigated and corroborated. This is unfair to the licensee and can bias patients. There is a requirement for the dental board to provide reports of all proceedings to licensees and persons lodging complaints. Not only is this outside the confidential manner in which complaints are handled, but this would have a large staffing and fiscal impact to the board. It could also compromise testimony and investigations. Furthermore, when the case is turned over to the Office of the Attorney General, the dental board is prohibited from further contact and has no information to report. Number four, the proposed bill states that the board will have to disclose personal and other identifying licensee information. The information should be protected as it is not releasable under the PIA. The open records could also disclose investigative techniques which are non-disclosable under the PIA. Number five, disclosing any information in a record of the board to the secretary and others is also concerning because there is the potential for bias or politicizing of investigations. Six, the proposed bill creates a public practitioner profile of information not required for licensing or renewal licensing and makes the board responsible for maintaining updates instead of the licensees. Lastly, the bill allows for a researcher to access the board's records on active cases. A researcher could be a legal researcher gaining unfair advantage in legal proceedings. Number eight, in conclusion, there is a significant financial impact of approximately $500,000 to implement this bill. The dental board opposes this bill for the aforementioned reasons and many more. The board is happy to consider a formal or informal study as an alternative to SB 836. Thank you so much.
Thank you, Ms. Kern. Mr. G.
Chairman Pinsky and members of the committee, thank you again. I'm Arthur G. of the Dental Board. The Dental Board wants to thank the drafters of Bill 836 for its intent and welcome support and improvements. However, the proposed Bill 836, as stated, is very problematic throughout. Therefore, the Dental Board opposes 836. First, the genesis of the bill is from a Dental Board case and subsequent fiasco, stemming from the then legal limitations, which require proof and incompetence to revoke a license. Effective in 2015, Maryland legislators passed the Dental Standard of Care Bill, which the OAG's office believes now prevents any similar case occurrences in the future. Thus, it alleviates any urgency for Bill 836. Secondly, the dentistry and medicine are two different disciplines requiring uniqueness to each board. Administrative differences, dentists have a limited license by anatomy, whereas physicians have unlimited license, meaning that a physician can practice dentistry. The dental board must use special permits, for example, an anesthesia permit, in order to practice outside of the normal dentistry. As stated, 90% of dentists work in offices, not hospitals, not ambulatory centers, and therefore there are no facility oversight committees nor discipline committees that are required for reporting. Already stated is the fact that licensees in this case should be responsible for patient-provided information, as in the medical board. This bill changes that around to have the board be responsible, which is inappropriate. Let me talk about the difference in the two boards. The Physicians Board has a staff of 68.5 PINs. The Maryland Dental Board has 13. The physicians have 8 investigators. The Dental Board has 1. The Physicians Board has a compliance department of 20 dedicated to compliance. The Medical Board, the Dental Board has 5. The legal staff and OAG support to the Physicians Board is 13.5 PIN positions. The Dental Board has 2.5. The statutory timeline for complaint to order is 18 months by statute for the physician's board. So that's the timeline. So in closing, the dental board just does not have the adequate manpower as the physician's board. The statutes are different, section and guidelines are different, violations are not different. In a revised estimate, the cost of the financial impact is upward to $500,000. Why? We will require at least 4 additional pins. In addition, we have a basic registration platform software that does not have the bandwidth regarding the information. We would have to have a sophisticated upgrade as far as how the board will be able to collect information.
Yeah,
So the board suggests
Mr. G, your oral testimony and is having problems. I think you're near the end anyway, and I think
I
you
am.
do a little work to have some technology assistance. We're not getting good oral testimony coming through the technology. So
I'll send it in written form to you.
thank you.
Thank you.
Questions for either of the 2 witnesses in opposition? Seeing none, that concludes that hearing. Thank you all for your patience. Now we're on the last bill of the day. It's 5:30. We have about 25 or 27 minutes. So we'll start with Senator Lamb. He'll be followed by Joyce Jones, then Matthew Lengel, then Nia Pandit, and then Aaliyah Horton. We'll take questions, then we'll move to the opposition, Allison Taylor from Kaiser, Matthew Celentano from the League of Life Insurance, and Pam Casemeyer. Other than the lead sponsor, we're going to hold testimony to 2 minutes so we can get through this and take any questions. Senator Lamb, as you know, we're under a tight time frame here.
Yes, thank you, Mr. Chairman. Let me try to press through this quickly. Thanks, Lamoria, for bringing up the slides. For the record, Clarence Lamb, Senator District 12 on SB 828. Some very quick background, if you can go to the next slide, on HIV, which is a major issue, obviously, here in Maryland. There are 31,000 people living with diagnosed cases of HIV here. And even just in the last year, there were over 900 people that were newly diagnosed. We rank number 6 when it comes to states with new rates of HIV diagnoses, and that's tied with states like Mississippi. And there are about almost 4,000 people that the CDC estimates live in Maryland that are undiagnosed. Next slide. However, there are medications that are very effective at preventing transmission of HIV. There's 2 of them that 2 classifications I'm going to touch on. One is called pre-exposure prophylaxis, or PrEP, pre-exposure prophylaxis. The other one is post-exposure prophylaxis, or PEP. Post-exposure is taken within 72 hours after exposure to HIV. According to the CDC, PrEP can reduce the risk of HIV transmission by as much as 99%. So it's very, very, very effective. However, accessing these medications can be difficult for people without a primary care physician or people living in more remote or rural areas. Next slide. So SB 828 would allow pharmacists to dispense PEP, pre-exposure prophylaxis, for up to 60 days total. That's 30 days at a time, or PrEP without a prescription. The bill would establish guidelines, including a training program for pharmacists to ensure patient safety. The bill would also remove insurance-related barriers to care, like preventing the use of prior authorization. It also requires insurers to cover tests that are required for the long-term use of PrEP, like kidney testing, kidney function testing. Next slide. PrEP and PEP are highly effective at reducing the transmission of HIV, but the timely access to these medications is really, really critical. PEP has to be, post-exposure prophylaxis has to be taken within 72 hours after a possible exposure, and requiring a physician's prescription can really present a barrier to accessing these medications because of that very short time frame. This bill also improves access to care, especially in rural areas without many providers. Research has shown that many people living in rural areas are much more likely to have long distances that they need to travel to access these medications, and pharmacy access could really help remedy some of these barriers. The bill would also increase access during the pandemic, with not many people going to their doctor. There have been studies showing that the number of PrEP initiations have declined almost by 3/4 since the start of this pandemic. That could represent a real backsliding in our progress against the HIV epidemic, which is concerning here in Maryland. And importantly, pharmacy access might help decrease racial disparities in PrEP and PEP access, particularly amongst the Black and Latinx communities as well, which have historically lower access to PrEP and to PEP. Next slide. The bill will also lower cost-related barriers to HIV treatment. The U.S. Preventive Services Task Force, which is the national body that sets things like breast cancer screening guidelines and such, issued a grade A recommendation to PrEP, which is the highest recommendation they can issue, which means that most insurance plans have to cover PrEP without any cost sharing. However, insurance plans are able to recoup the cost of any ancillary services that there need to be done as a result of PrEP. This creates a barrier to access where patients can't afford to get PrEP drugs, but they can't afford to get the testing or any of the ancillary services required as part of them. The bill also requires that plans use PrEP to cover, the plans that cover PrEP have to cover ancillary services required for the use of PrEP, like kidney function testing and hepatitis B and C testing. Additionally, this bill would also require that those plans cover PEP pre-exposure or post-exposure prophylaxis. So patients exposed to HIV can also access this treatment. Next slide. Other states have already led the way on these medications. Colorado and California allow pharmacists to dispense PrEP and PEP, and New York allows PEP only. And just last week, Virginia's House actually passed a very similar PrEP pharmacy access bill. And you can see there is a list of other states where there's similar legislation that's pending as well. Next slide. It's important to consider patient safety. So we wrote a number of provisions into this bill to protect patients. The bill requires that all people initiating PrEP or PEP in a pharmacy have to have a negative HIV test to prevent the proliferation of treatment-resistant HIV. So if you already have HIV, giving someone PrEP or PEP could lead to resistant forms of that virus. It also requires that pharmacists provide referrals to providers for follow-up care and creates a training program for pharmacists seeking to provide PrEP or PEP. Importantly, the bill also creates a new access point for Marylanders to be able to be connected to HIV-related care, and thus just further protecting the health of the whole. We do want to note that in conclusion here, the bill would help more people access medications to prevent the spread of HIV and also help create more access points for HIV-related care. Other states have already implemented similar legislation and many more are considering it. For these reasons, I urge a favorable report. Happy to pass along to other members of the panel. Thank you.
Thank you, Senator. Ms. Jones, and again, folks, I apologize, but we don't want to reconvene at 8 o'clock for the rest of the hearing. So let's try to keep the 2 minutes. If you can avoid reading, just tell us, speak from the heart and tell us what's on your mind. Okay, Joyce Jones, followed by Matthew Lengel.
Thank you very much, Chair Pinsky, Senator Lamb, and members of the committee. I'm Joyce Jones. I'm a physician and an assistant professor at the Johns Hopkins Department of Medicine, Division of Infectious Diseases, and I am the Associate Medical Director of the John G. Bartlett Specialty Practice, which is the infectious disease clinic at Johns Hopkins. I'm a member of the Baltimore HIV Planning Group and the Maryland State Planning Group as well, and want to thank you for this opportunity to testify in strong support of Senate Bill 828. As Senator Lamb has described, PrEP and PEP are highly effective in preventing HIV infection and play a critical role in the national and the Maryland state plan to end the HIV epidemic. We know that states that have higher increases in uptake in PrEP have shown greater declines in new HIV diagnoses, but PrEP and PEP are underutilized, with only 1 in 5 people in the US who could benefit from PrEP actually getting it. Pharmacists are highly skilled healthcare professionals and across the country have been enlisted to safely and effectively expand access to PrEP and PEP. By allowing trained pharmacists to initiate and dispense PrEP and PEP, patients at high risk for HIV who otherwise would not gain access to PrEP and PEP can start these highly effective preventive medications. Barriers for not accessing the medication include not having a primary care provider, not engaging in routine medical care, not feeling comfortable discussing their HIV risk behaviors with their providers, or not having a provider who offers PrEP or PEP. Through pharmacist initiation of HIV prevention medications, these patients can start PrEP or PEP and then get linked with the medical provider to continuity care. So I see pharmacists as great partners in gaining access for people at high risk for HIV to start these preventive medications and then referring them to providers for continuity care. They have the skills to safely and initiate prescription medications, as demonstrated here in Maryland, where pharmacists are playing an active role in addressing the opioid epidemic by dispensing naloxone, a prescription medication that reverses opioid overdose. We should be enlisting pharmacists in our fight to end HIV as well.
Dr. Jones, you're going to have to wrap up.
Okay. I also want to tell a story in terms of the insurance aspects.
Briefly.
I'm HIV prevention specialist, and just a couple weeks ago, there was an 18-year-old young woman who had been sexually assaulted. She went to an emergency room, got the appropriate exam, and was prescribed PEP. She went to the pharmacy to fill the prescription, but could not fill it because her copay was thousands of dollars. She was referred to us, and it was too late to give her that medication. So I strongly support both aspects of this bill. I think it will increase access to PrEP and PEP to Marylanders who otherwise do not have access and are at risk for HIV. We have the opportunity to end the HIV epidemic, and this bill will help us move toward that goal.
We're running very late, and we have to adjourn soon.
Okay,
I
thank you.
apologize. Matthew Lengel, then Nia Pandit, and Aaliyah Horton.
Yes, thank you, Chairman Pinsky and members of the committee. I'm honored to be here today. My name is Matthew Lengel, and I strongly support this bill. I'm a pharmacist and a clinical pharmacy manager at the Johns Hopkins Pharmacy and John G. Bartlett Specialty Practice. As mentioned by Dr. Jones and Dr. Lamb, PrEP is highly underutilized within our country, and on average in Maryland, 3 people are diagnosed with HIV every day still. As leaders in the state, I think we need to not accept this and look at the current care paradigm and see that it's not working and see how we can improve that care delivery system. So communities that would benefit most from PrEP and PEP face multiple barriers to its uptake, including lack of education, high cost of drugs, low access to healthcare providers, and sexual health services. Pharmacists are highly educated healthcare professionals positioned within these communities. Pharmacists are able to address many of the barriers to PrEP and PEP initiation by providing convenient, quick, and safe spaces for patients to access therapy, receive education, and get connected to a PrEP physician for long-term follow-up. Speed is of the essence, especially with PEP. As we mentioned, it needs to be done within 72 hours, but it is most effective if started as soon as possible. Based on this legislation, all participating pharmacists would be appropriately trained, and process standards would be outlined and approved by the State Board of Physicians and other relevant stakeholders. This, along with the pharmacist's already extensive background knowledge and training, would ensure safe and consistent patient assessment, care, and referral, similar to the contraception bill, which is already occurring. This legislation would help reduce the barriers that Joyce mentioned with insurance coverage. The cost of preventative therapies for these things are much more cost effective than the lifetime cost of treating a patient for HIV, which is close to $500,000. So in summary, I urge the committee to support ending the HIV epidemic and protecting Maryland residents at risk of acquiring HIV and voting favorable for this bill. Thank you for your time.
Thank you, Mr. Lengel. I don't know if it's Ms. Pandit or Dr. Pandit, but you're next.
Neha Pandit. Hi, everyone. I'm here also to express my full support for SB 828, and I'm going to try not to repeat a lot of the things that have already been said. I'm an associate professor at the University of Maryland, Baltimore School of Pharmacy, and I'm one of the HIV clinical pharmacists at the University of Maryland Thrive program. Already mentioned, PrEP is underutilized since its inception in 2012. If we did have widespread use of PrEP, we could actually reduce the incidence of HIV by 31%. So it's really imperative from a public health standpoint that we really push PrEP to be something that is standard across the board. The Global Advocacy for HIV Prevention stated that it's hard to go to a pharmacy and not hear about flu shots. Awareness for PrEP should be just as widespread. There was a study that was done in Baltimore City that people who initiated PrEP 1 year later, only 41% of them were still on PrEP or still engaged in PrEP care. Some of the barriers that the studies have really identified include insurance issues, scheduling problems, transportation. If we can really support some of those services at pharmacies, we can help patients get re-engaged, get them access to medications in a much timely manner. I just want to mirror that there are 3 different things that pharmacists really do that almost are parallel to what's happening in this bill, and that is oral contraception, naloxone, vaccines. And they have the training to do this. They're ready to do this. They're ready to help the HIV epidemic. They're ready to do all of those things that they already do for some of those other 3 sort of bullet points that I noted earlier. So I strongly urge each of you to really provide a favorable vote for SB 828, because this would really mean the ending of the HIV epidemic for the state of Maryland.
Thank you, Professor Pandy. Is Ms. Horton with us? I don't see her on the screen.
No, she wasn't available today.
Okay. Let's take limited questions for the proponents, and then we'll go to the opponents. Are there any questions, committee members? Any questions, committee members? Senator Vice Chair Kagan.
Thank you, Mr. Chairman. For Senator Lamb, or for anyone, actually, a 2-second question. You have to be HIV negative before you start PEP or PrEP. How long a lag time is between exposure to the virus and evidence in a test? Is it hours, days, weeks? I don't know.
It depends on which type of HIV test is done. So depending on the test type, it can be as positive as soon as 2 weeks to a week, or it can take up to a month or 2.
Yeah, it's definitely not hours.
Okay, Senator Lamb, I may ask you questions. I mean, how do you know then if you've had potentially risky behavior, if you're talking about potentially a month or 2, and yet time is of the essence? I'd love to understand that better. But again, time is of the essence, so I won't wait for an answer there.
Yeah, maybe I can follow up with you offline.
I would love
afterwards.
that. Thank you. Thank you, Mr. Chairman.
On the same issue, if you had exposure before you get the PEP or the PrEP, you've got to do a blood test, correct? So go ahead.
Go ahead.
In other words, if someone comes to the CVS pharmacy, do you send them to the local LabCorp to get a blood test and then get the results back before you can prescribe the PEP or PrEP?
So PEP includes the same medications we prescribe for HIV treatment. And so they would do the HIV test if it was negative. They would give PEP and then connect them for continuity, and we would do additional testing there. For PrEP, even if they are HIV positive, dispensing the amount of medication that's being proposed in this bill has a low risk of causing harm if the person is in fact HIV positive. So we would, that's
okay. Again, I have more questions. I'll keep them offline as well. Let's go to the opponents. Let's start with Allison Taylor from Kaiser, followed by Matt Celentano from the insurers, and Pam Casemeyer from MedCai.
Good afternoon, Mr. Chair and members of the committee. My name is Allison Taylor, and I'm here on behalf of Kaiser Permanente today. I would agree with a lot of what the proponents have said. We think access to PEP and PrEP is really important, and we also see this as not just a medication, but a comprehensive system of care. As Senator Lamb mentioned, there's a lot of ancillary care that goes along with this. We have concerns with a number of parts of the bill. We have a pharmacy-based PEP and PrEP program at Kaiser Permanente, but it's heavily overseen by our physician leaders, and the physicians work very closely with our pharmacists on it. That is not really what's envisioned by this bill, and so we have concerns. We really think that physicians need to be a major part of this. Moving to some other concerns, the bill requires Medicaid to cover these medications. I believe Medicaid already does cover them through health choice, so that language may need to be looked at, or it may not be necessary for this bill. Moving to some of the insurance pieces, appreciate what was said about insurance concerns. One thing I would note is in 2016, the Maryland Department of Health had a departmental bill that was passed by the General Assembly creating a special fund that would fund services associated with the state's HIV priorities, which noted in the fiscal note for that legislation included services associated with PrEP. The fiscal note noted that there's potentially over $3 million in that special fund as of projected by 2021. So before we do any kind of like prohibiting of cost sharing or anything related to insurance, I think it'd be prudent to look into what the Department of Health is able to provide for this population. Happy to be part of the conversation going forward, but as written, we urge an unfavorable report. Thanks.
Thank you, Ms. Taylor. Mr. Celentano.
Thank you, Mr. Chairman and members of the committee. My name is Matt Celentano on behalf of the League of Life and Health Insurers here today in opposition to Senate Bill 828. We also support PrEP and PEP, but we cannot support this bill as it has been introduced. It's important to remember that PrEP is not just a medication, but a comprehensive program to prevent HIV, and authorizing direct access at a pharmacy could have negative consequences. Strong value-based care and care management through your primary care physician or through a care management program are essential to strong education around prevention and adherence. We believe this direction should be physician-led. There is also guidance from the U.S. Preventive Services Task Force from the summer of 2019 that PrEP should not be recommended for all patients, regardless of risk of acquiring HIV. This raises the question of whether community pharmacists will have the appropriate time or clinical background to make appropriate recommendations on a patient-to-patient basis. In addition to this concern, prescription drug plans are designed to cover drugs dispensed under a prescription. It is challenging to manage claims appropriately in the absence of a prescription to ensure that the patient is covered appropriately. It's even more difficult to do with an out-of-network pharmacy that doesn't have the ability to access the plan's electronic system. Another concern is that carriers in this bill would have the ability to use prior authorization as a tool to control costs taken away. This is especially important for some of the PrEP prescription drugs like Truvada, which had increased about 50% in the list price in the first 6 years that has been on the market. Well, just as effective generics and much, much cheaper are coming online. Without that prior authorization, we're going to be spending money that we should not be spending. And lastly, like my colleague from Kaiser said, Allison, Maryland already has a funding source to help offset the insurance costs associated with the PrEP and PEP programs. The special fund that was created in 2016, MDH identified as a source, quote, to be used for state identified priorities for HIV prevention, surveillance, and care services. This fund would adequately cover the cost of the PrEP program for Marylanders in need without having to prohibit cross-sharing as written in this legislation. So for those reasons, we urge an unfavorable report on Senate Bill 828.
Thank you, Mr. Celentano. And finally, Ms. Casemeyer.
So that you don't have to sprint across to the State House, I'll be super brief. I want to differentiate my opposition a bit from my insurance colleague friends. MedKite actually believes the insurance portion of this bill and the cost sharing provisions have validity that should be discussed further, even possibly right now for this year. The concern that the clinicians have is the initial part with the pharmacists. Unlike some of the other bills today you've heard me oppose, we actually think there is a framework in these circumstances where the pharmacy physician interaction could be similar to what's in this bill, but it needs a little more. We're here opposed because it needs some further dialogue that I'm not sure we can do in the next 45 days. We had a number of questions like there's nothing in here that keeps someone from pharmacy shopping. So I get 30 days here and then I get 30 days there because I'm really nervous about going to see someone. There's a big difference between post-exposure prophylaxis and the medical services versus pre-exposure. This bill has both. Ordering tests is a problem, so I won't repeat all of that. You need to go, but I think what our concern is there's a lot of unanswered technical questions framework-wise that have pretty significant consequences if not done correctly, even though we would say this is a very good dialogue that should proceed forward.
Thank you. First of all, committee, I alerted the Senate President's Office. It's okay if we're a couple of minutes late. So we'll take a couple questions if you have them. So the floor is open for any questions of the opponents. Seeing none, hopefully that was enough wait time. Thank you all for your patience. It's been a long day and it's going to get longer for some of us. Thank you all. That concludes our hearings today. Committee, I told them we might be a few minutes late. So if you need to walk or do a bathroom break at the conclusion, obviously do what you need to do. That ends our hearings for the day. Thank everyone.